It is a great honor to welcome each of you here today to Berry College. We're very, very appreciative of President Briggs and his wonderful leadership. He informed me that his football team is undefeated, which is obviously very, very nice for a new stadium out there. But this is a wonderful crowd, and we are very, very appreciative to be here, and we appreciate him and his willingness to open up the campus for us today as well. I would first like to ask Senator Huffstetler if he would to give an invocation.
Thank you all for being here and welcome to my hometown and the largest campus in the world here, and what many have ranked it as the most beautiful campus back here. That some areas that you probably won't even see today, but it's great to be here. And if we could all bow our heads. Our dear Heavenly Father, we do thank you for all that you've given us, for all that you've blessed us with. We know you've been good to us, and we thank you for that. And we thank you for the beauty of the world and the beauty of this location. We do ask your wisdom and your guidance today as we struggle with solutions to help those that need better solutions to improvement of their life and long-term solutions for the improvement of their life, that we could help be a vehicle for that. And we ask your guidance in everything we do today, and we do it all for your honor and your glory. We ask this in your name. Amen.
At this time, I'd like to ask President Briggs to come and give us some opening remarks on behalf of Berry College. Thank you.
Let's give him a warm round of applause.
Thank you. The newspaper said something this morning about a keynote address. I promise you this is not a keynote address. This is merely a welcome. But we are delighted to have you here at the college. Since our founding in 1902 by Martha Berry, we have been about the business of attracting talented students from Georgia, surrounding areas, surrounding the states, and regionally, and preparing them to be the infrastructure. Part of the infrastructure of our communities, both our small towns as well as our big cities. So we love to participate in the process of developing the infrastructure of our state. The economic development of it, the healthcare system, half our students come in the sciences, and in education, and lots of other areas as well. We try to provide a very challenging academic program with an equal part emphasis on practical experience. Most of our students work while they're here on campus. But most importantly, perhaps we also want to challenge their hearts, because we know that it takes a moral compass, a sense of moral direction, really to make a difference for our communities and our larger society. So we call that an education of the head, heart, and hands, and that's the completion of my introduction to Berry College, my big promotion there. So thank you for joining us. If you have a chance on one of the breaks, just stroll out here on the veranda, and you'll see a beautiful scene right there that gives you a taste of the beauty of campus. We're here for a far more important reason today, however, and we're delighted to host this particular session on primary and preventative care. We all know that our nation has a problem. We spend more than any other developed nation in the world in our healthcare system. One report out a few years back before Affordable Health Care Act, we spent 17.1% of our gross domestic product on healthcare, compared to 8.8 to 11.6 of all the other developed nations in Europe, Australia, Japan, Canada. Higher out-of-pocket costs individually, higher private health insurance costs, and higher public costs than most all other nations. And so we're not high just on one, we're high on all three areas. And yet we have poor health outcomes. Shorter life expectancy than any of those nations, greater prevalence of chronic health conditions. We visit doctors less often. We visit hospitals less often. We spend more on diagnostic imaging, MRIs, CTs, PET scans. We spend more on pharmaceuticals. We have cut the incidence of cancer, but we're losing the battle against ischemic heart disease. So we have a problem that's national, it's statewide, It's local here in Floyd County and Rome as well. And so primary care is a vital ingredient to any solution. So I'm delighted that you're here today to talk about primary and preventative care. We need systems that will take us into the future in a way that will make us healthier at a price that we can afford. We like to think of places like Barry as being the primary care providers for a lot of our educational systems here in the state. So we believe in primary and preventative care in the sector, but we're delighted today to host this session because I think this is one of our nation's greatest issues facing in the next 20 years. How do we get this under control? So Lieutenant Governor, we are delighted that you're here and wish you all the best for your task force. Thank you so much. Appreciate it.
Thank you very much, President Briggs, and again for you opening up your campus and your remarks as well. At the beginning of the year, I, along with the senators here, and let me take a moment just to introduce them. To my left is Senator Dean Burke from Bainbridge, and all of you know Senator Huffstetler, who we happen to be in his great home now. We appreciate both of them, and obviously they're both practitioners as well. Renee Unterman, who chairs our Health and Human Services Committee, along with Kate Kirkpatrick, who's here, is also a practitioner. Senator Butch Miller from Gainesville, he is a practitioner, but certainly not in healthcare. Amen. And then Senator Brett, there from Cobb County, who is a part of our task force. We appreciate you being here as well. Obviously, the healthcare task force has taken on a wonderful beginning and a very good start, and really is focused so we could prepare statewide for the challenges of healthcare reform. Today we will focus on primary and preventive care and spend most of our time this morning discussing the overall health of Georgians and solutions for how we can improve the delivery of quality care at low cost to empower more people to live healthier lives. We will hear presentations from individuals who are leading at the local, state, and national level. And I hope after this meeting, everyone will leave more optimistic about the opportunities waiting in our state's future. Because if we work together and bring a true innovative approach to solving the challenges we face, we will get more Georgia families access to high-quality, affordable care and strengthen our fight to defeat major threats to our health, like the opioid crisis, cancer, and chronic diseases. Primary and preventive care gets to the core of healthcare system because it covers the overall health of every person, from before we are born until the very end of our lives. The quality of primary care available not only affects everyone here today, along with all Georgians, because it influences the landscape of how we deliver and pay for our health care, but it also shapes how we each live our own lives and what we do day to day and year to year to stay healthy. The importance of quality primary care is also demonstrated by the most persistent challenges we see across our rural communities, where health outcomes are often made worse by other circumstances, which also causes people to do and go without care until serious health problems arise. There may be nowhere there. This is more evident in the 40 counties across Georgia where more than 40% of children are living in poverty. But the same challenges exist in communities statewide. And to address them, we have to bring innovative approaches that will break down barriers to regularly access quality care, putting more people in control of their own health, improving access to quality care. Health care should not have to be bankrupting for our state with out-of-control government programs or forcing our families to access 50% increases in premium costs each year. The path to a more affordable system starts with prevention, strengthening the doctor-patient relationship, and taking advantage of technology and medical innovations to make the delivery of quality care less expensive. It also means developing a skilled workforce that is second to none, and growing our economy to create better jobs that allow hardworking Georgians to earn more. Although we must have strong leadership statewide, under a strategic plan and a vision to keep all Georgians healthy, I don't think I can overstate how important it will be to continue building partnerships at the community level, to work with carriers, providers, doctors, and nurses to innovate and lower the cost of care, premiums, and deductibles so that all our families have access to the care we need at a price we can afford. I want to recognize Senator Huffstetter for helping to plan this meeting and hosting us here today. Thanks to each of you, along with the presenters that we have present today. Our first presenters today will consist of Redmond Regional Medical Center, followed by Floyd Medical Center, and then we will hear from Harbin Clinic as well. First of all, let me ask Redmond to come forward and be the first presenter. Thank you.
Good morning. My name is Andrea Pitts, and I'm actually the Director of Marketing and Public Relations at Redmond. And on behalf of Redmond, I want to welcome you all here to Rome, Georgia. Our CEO, Mr. John Herman, sends his regrets that he could not be here in person to welcome you himself and give remarks. He's actually at this moment conducting our quarterly employee forum town hall session. So those were previously scheduled, and he wanted to honor that commitment to our employees, but he sends his regrets. I wanted to just briefly share a little bit with you about what's going on at Redmond, and also to say thank you to the Lieutenant Governor, the senators, and the committee members, and all of our distinguished guests here. And also a little bit, John had shared with me that when Senator Huffstetter first approached him about this meeting, top of the list was lunch. So, so we're also, along with our healthcare partners, helping you to provide that as well today. So Rome has long been a medical hub in Northwest Georgia, and really going back to the Civil War and further than that, the confluence of the rivers have really made this a natural hub for healthcare in this area. And soon after, the Harbin brothers began what is now known as the Harbin Clinic, the largest physician-owned specialty group in the state of Georgia. And Redmond is proud to be a part of the excellent healthcare offerings here in Rome, along with the Harbin Clinic and Floyd Medical Center and the many other healthcare partners in our community. So as the task force works to address the issues of need in primary and preventative care, mental health, drug treatment, and so many more, know that these are also areas of concern to our healthcare community here as well. And we're proud to host you here and provide our input and support in the dialogue. So there are many exciting things happening in healthcare in Rome, and our community again is pleased to welcome y'all here to help work towards solutions in these areas of critical need that impact our citizens around the state. Since opening our doors on July 4th of 1972, Redmond's been proud to offer many medical firsts in Rome and Northwest Georgia, including the first diagnostic cath lab in 1975, and then 10 years later, the first interventional cath lab and open heart surgery program. But specifically as it relates to primary care and preventative care, our occupational health and medicine program that began in 1996, so for over 20 years, has really been kind of pushing that envelope of what we can do to offer preventative and wellness care on-site in wellness clinics on-site with employers and partnering with those around Northwest Georgia. Most recently, we were pleased to operate the wellness clinic here in town locally that serves both the city of Rome and Floyd County employees. And again, using that as a way to offer wellness and preventative care at a cost-saving solution for both of those entities. And I know that many others in town do similar things as well. So that's one of the things that we have done for the last 20 years and will continue to do as the years come. Another thing new happening at Redmond is we are now in the second year of our new internal medicine residency program. This was important. We brought this here because of the need for primary care physicians in rural Georgia. And while those of us who live here in Rome may not think of ourselves as rural Georgia, we are considered rural Georgia, and there is a need, not just in Rome, Floyd County, but Northwest Georgia. And so studies have shown that with a residency program, with a training program, those trained physicians are more likely to stay within about a 60 or so mile radius of where they do their training. So again, the hope is that these physicians that complete their internal medicine residency training at Redmond will stay in this area and help serve that need for more primary care. Looking to the future, one of the things that we, and I'm sure many of you that are in this area are well aware of, one of the things we look towards is the ability to add a psych residency program, again, to serve that need, that great need in our area for behavioral health services. And so we want to also, that's just a brief, really quick overview of the things that are happening at Redmond. If you have questions, I'm happy to try to entertain those afterwards, but I don't want to take up too much time. We do thank the task force for the work that you have done and will continue to do to address healthcare concerns for the citizens of Northwest Georgia and around the state. And again, on behalf of Redmond Regional Medical Center, welcome to Rome.
Floyd Medical will be up next.
Hello everyone, I'm Jamie Brennan from Floyd Medical Center in the Floyd Corporate Health Department. We at Floyd have, like Redmond says, long have been in the business of providing services. We want to provide services where you live, where you work, and where we play. We've provided services in the primary care network for many years. We are in Floyd County, Polk, Bartow, Chattooga County in Georgia, but also over in Alabama at Center as well. One of the reasons you guys are here is knowing how the expense of healthcare has increased. As insurance has changed, so has habits regarding healthcare. Out-of-pockets have increased, so more and more individuals are no longer pursuing healthcare or primary care in the same way. That doesn't mean the need is not there, it just means they're no longer able to afford the options or work is creating obstacles. So our department, I'm blessed to be part of a team that we get to identify problems and then work to create solutions to provide services where we work and where we play. Like Andrea spoke, with Redmond, we provide lots of services on site to manufacturing and local industry. We have on-site nurses that meet one-on-one with individuals for wellness coaching, for triage of current acute illnesses as well as chronic illnesses, working to create what are your obstacles and how, as that nurse, out as their industry, their employer, what can we do to help create those solutions for them. We've recently also started putting nurse practitioners in clinics with the ability to provide on-site dispensing. Being able to see the nurse practitioner, identify that I have uncontrolled diabetes, and before I leave to go back on the floor, I can have my medicine. I then know that she's just around the corner in a week. I don't like to take the medicine, it doesn't make me feel good. I can come right back, we can try a different solution. The medical adherence has greatly improved because it's convenient, it's cost effective, and it's there. But we've also, when last April came around and the Department of Health decided we're no longer going to provide school nurses, we realized that was another opportunity for Floyd Medical. If we can also be where we play, we have a greater avenue to meet the need. We are able to be on site at 27 schools with 24 nurses. We provide all the nurses in Floyd County, Rome City, as well as Polk County this year. They're there to provide one-on-one case management for our students. If we have a diabetic We're there. We track daily all of those glucose numbers. Sometimes they may be the first to identify a student that is no longer being managed. They've then become the case manager to work with the parent, to work with the schools, the principals, the teachers, but also that pediatrician to say, we need to work with this family. What are the obstacles this family is experiencing that is not allowing this child the best help? We've known to go on site to their homes, to work with meal preps. Any education regarding what is safe lunches, what is not, what should be in a book bag, what should not. We really have the avenue to not just meet the parents' need, but also to start with that student. For them to realize early on that their health is very important. It will help them in long-term success. Using those school nurses, we've been able to provide EpiPens to all the local schools. They receive 4 EpiPens free of charge, and as those are used, they're replaced. In the last 12 months, we've had to administer those 3 times. And all of those were for elementary school kids that had undiagnosed allergies, that EpiPen allowed, provided by that school nurse, saved that student. Got them the time to get to an ER to receive the further care that they need. But we've been able to provide those to the schools, like I said, free of charge. The most recent was on Friday, a little 5-year-old that got stung on the playground. Swelled up, the tongue immediately started swelling, and the nurse was able to identify that immediately. We've been able to provide one forum on teen suicide that was held in Floyd County, but also one in Polk County for all of parents, teachers, to identify what are signs and symptoms. What would you be looking for if your adolescent was entertaining those ideas of suicide, all based on the 13 Reasons Why documentary that's out. Next month, they've also got one that is scheduled that's regarding dependence of students for alcohol and opiates. It's everywhere, you know, it's our adults are experiencing, but so are our students. So finding ways that we can target, provide that education. We provide a free meal, invite everyone out. If you're not able to attend, it's streamed live on Facebook. So there's that opportunity as well. With the school's nurses, we work with athletic trainers. We're there for all the athletic games. We're there, we have the EMS team, but we also have an athletic trainer that works with those injured athletes to ensure that they do not get back on the field, on the court, until they're safe to do so. They work between the parents, the coaches, the schools, the doctors. No one's back on the field until it's time to be back on the field. Recently, there's been some discussions with Floyd County as well as Rome City Schools to establish a nurse practitioner clinic that would work on site at the schools. It's very early on in some development phases because we have to figure out what does that look like. But we do know that once you get to middle school, those students are no longer receiving health care. Their health care is urgent care or the ER when they break a bone. They're not going to get well checks. They're not being followed unless there truly is an emergency. So finding a convenient way to provide those services, particularly to the middle school and high school students, so that we're not impacting their parents' work schedules, they're not having lost time or lost wages, but also meeting the needs of those students. Just a few opportunities we have going on. We're very thankful that you guys are here, very excited for the opportunity. Appreciate your time.
Next up will be Harvard Clinic.
Good morning. I'm Ed McBride. I have the privilege of serving as the Chief Medical Officer of the Harvard Clinic, and as others have done, I want to welcome you here to both Rome and Floyd County. The Harvard Clinic has been around for over 100 years. It doesn't look anything today like it did 100 years ago. And I often remind our physicians that it's unlikely that 100 years from now that it looks exactly like it does today. The way we deliver care today is different than it was 100 years ago. And likely, whether it's technology or advances in healthcare, that likely is going to change. A little bit about the clinic itself. We have roughly 150 physicians and 100 advanced practitioners serving in various clinics and specialties across our organization. That includes surgical specialties, medical subspecialties, and primary care. The Hartman Clinic, once upon a time, was the hospital in this community. When the community decided it wanted to build a public hospital, we took a step back, and that's really the point at which we became a clinic model. And we support our local hospitals, both Redmond and Floyd, in this community. At one point in time, Harvard was the nursing school and the provider of nursing education in this community. Today, we have nurses rotating through each of our clinics and specialties across our organization, learning and growing alongside physicians in our clinic. So the various iterations that the clinic has undergone in order to help meet the demands and the needs of our community, I think will continue. There are some challenges though, and I think this task force in particular has been charged with examining and evaluating how do we meet those demands. If I'm correct, I think our primary care folks, and I'm a family physician by training, first and foremost, long before I ever was called to serve in this capacity, we're graduating roughly the same number of primary care folks every single year from residencies. Dr. Reed, that's not changed, has it? Not the market. Okay? How do we keep up with the demand, with the graying of America? Who's going to take care of the next generation? Okay? How do we advance that? What we have done to date, if you look at the clinic as a whole, we have added a number of physicians in the last few years, but our rapid growth in the clinic has really been by adding advanced practitioners to the care team. And really changing the model in which care is delivered across our organization. Patients often say, we want to be involved in the decision. Well, engaging patients and helping them to become active, engaged participants in their care is a major challenge for us. Someone noted that a large portion or a portion of the social determinants of health weigh into, those are outside our sphere of influence, but weigh into the health of our community, our patients. Roughly 20% are in our direct sphere of influence. While we focus on those things, I think we have to take a step back and say, what are the other things that we can do to help folks care for themselves? When you look at growing primary care in our community, our organization supports both Floyd and Redmond's residency programs to a certain extent. Those students rotate through a number of our specialties as they're going through the clinical rotations, preparing those young folks to serve as they come out and assume the mantle of responsibility for providing care for a group of patients. I think that will continue, and I second the need for more mental health services. When you look at the cost of health care, I think the studies have shown that when you add chronic disease to mental health disease, the cost of providing care for those individuals goes up by a factor of 3 to 5 times. That's incredible. The clinic is currently in the process of evaluating how do we migrate from what has traditionally been fee-for-service to what is value-based care. Value-based care meaning how are we compensated for the care we provide? How do we assume responsibility? Are we large enough to assume risk? Is our patient panel large enough to do that? Some of the challenges, how do we engage patients? Well, we engage them one-on-one. As a family physician, when I was caring for roughly 2,500 patients, I saw population health as serving one patient at a time, one family at a time. Now it's my responsibility to make sure roughly 500,000 people get the care they need. How do we do that? How do we determine who it is that we need to outreach to? I think technology will help us with that. We have a clinical integration department and care coordinators that we are gradually increasing as we get into more and more of these value-based contracts, in which we are not only encouraged, but we assume responsibility financially for the care of those patients. So these are nurses, care coordinators who provide proactive outreach and engagement with patients. How do we identify who those folks are? I think technology is going to help us a bit with that. Likewise, telemedicine is one of those areas in which we'll be able to provide care to patients at their point of need, when they need it and where they need it. So there's a lot of opportunities before us. I look forward to addressing those challenges with you, to working with you, and I thank you for the opportunity. Lieutenant Governor, y'all have a wonderful day, and look forward to all the conversations. Thanks.
Senator's got a question.
This is a working meeting, so I hope you're prepared.
Yes, sir.
What are y'all specifically doing from a primary care standpoint? Are y'all in any ACOs and are you doing any work with community health workers getting out in the neighborhoods? Are you doing primary care medical home model? I mean, what specifics are y'all doing? What seems to be working, moving the needle, and what do you need more help or support for? Thinking about from a Medicaid or the part that we have some control over, state government.
Yes, sir. So in preparation for caring for large populations of patients, one of the models that we've chosen to pursue within the clinic is the National Committee for Quality Assurance Patient-Centered Medical Home Initiative. That puts the infrastructure, the processes, the policies into place, and then helps folks begin to focus upon both preventive, acute, and chronic disease within the medical home itself. I'm proud to say that each of our primary care facilities is currently recognized by the NCQA at their highest level, level 3 recognition. We are not participating currently in the Medicare Shared Savings Program. I have personal experience having served in leadership in one of those. I think the model is evolving. Hopefully we'll get to the right recipe, but it's really a challenge when 75% of those folks don't generate enough savings, or don't generate any savings, and of the 25% that do, don't necessarily generate the savings to cover their cost of the program itself. So that's obviously, from a business perspective, a non-starter. We have to figure out ways of actually incentivizing that model so that we can actually, in confidence, go into those type of things. Again, our population may not be large enough to insulate against the costs that invariably are going to occur. Patients will get sick. So how do we ensure that when folks go into those type contracts and willingly take on that risk, that we're able to do so without fear of bankruptcy? You know, a number of the organizations that I've had the privilege of knowing over the years now are no more because they got into such debt. They took the leap of faith in this transition to value-based care and actually borrowed substantial money, put substantial infrastructure in place to address both an informatics perspective, but also an engagement perspective. And now folks like Cornerstone in North Carolina are now part of WakeMed. You know, and half their physicians have chosen to affiliate elsewhere. So it's a challenge on how we very intentionally make no regrets decisions as we're determining that. How do we address things today that are going to position the clinic for success so that we can continue to provide the needs of this community? I think increasing our engagement with mental health. We're doing some novel things in that area. Frank Harbin is in the room, so I'll give a shout out to the initiative that he brought forward around treatment of refractory depression. You know, by the time you get to the third and fourth grade, the chances of you finding the right recipe for medication for that patient to help address that refractory disease is, well, poor. There's a new process that we're piloting right now that uses quantitative EEG testing to actually evaluate patients and determine what's the best drug for that patient. And it's interesting sometimes what comes back are things that we would not have thought about. And patients are actually responding to that. So we're early in the process, but we're looking at how do we apply technology and new solutions to address those situations. Yes, thank you.
Thank you, Dr. McBride. Next up, I'd like to welcome Monty Veazey, who's the president of Georgia Alliance of Community Hospitals, who will introduce a video and make a presentation as well.
July 3rd of this year, I went over to visit with Dr. Kinsel and some of the people who support her clinic. It was that old Tasty Fruits building that had closed. I was shocked to see the facility that she worked in. She's the only physician in Clay County. I don't think she's been paid 2 years.
I came to Clay County because it was the worst place in Georgia in terms of health status. I wanted to be someplace where I was needed, where I could use the skills that I'd learned to help people. The community is a beautiful place. Clay is a part of Georgia. We're connected, our families are connected with the other parts of Georgia, as well as the rest of Georgia uses our resources, our water, our lake, our farm products. And we have a lot of people that have been left behind. But you shouldn't have to be sick or unhealthy to live in Clay County. You shouldn't have to die to live here. There is no hospital in Clay County. Ours closed in 1983. There are small hospitals 20 or 30 miles away from us in different directions. One of those is already closed. Several of the others are under a lot of significant pressure, and we hope they'll be able to stay open. Emergency services are a particular problem out here due to the distances. I mean, it's 20 miles to any hospital, but it's 40 or 60 miles to a hospital that can really deal with trauma. Getting those patients to the hospital can be a real struggle. For a long time in Clay County, we didn't have working ambulances. Things in Clay County are pretty limited. We don't have x-ray machine, we don't have EKG, we don't even get lab work back till the next day. So when you walk into a room with a patient, you've got to be able to know how to diagnose a patient without all that technology. Providers who work out in rural counties really need to be more highly trained than people would need to be if they worked in a city where they would have colleagues to ask and a lot of technology to help with diagnosis. We have one receptionist, one full-time nurse manager, and then several part-time nurses. Basically, slightly over 3 people for the practice in addition to myself. People from Clay County as well as from surrounding counties, about 60% are African American, 40% are white. Internists are trained to handle most medical problems of adults, but often it comes up that patients need a specialist of some kind, either a heart doctor, kidney doctor, or something that I can't provide here. We have tremendous problems getting those services for patients. The first thing, they're a long distance away. People either don't drive, can't drive, don't have the gasoline, don't have a car in some cases. And furthermore, they often can't afford the cost of a specialist. Obviously, I can't do surgery here or do a CAT scan here. People, if they cannot get those services, really are not getting modern health care. When patients need a specialist, they really need a specialist. I mean, I don't know the things a specialist know. Communication is a real problem out here. At the clinic here, our internet speed is not fast enough really to run the computer, the medical records correctly, nor to run a telehealth system. We would like to have telehealth. What we would use it for would be for follow-up visits primarily for patients who've already been to a heart doctor, a kidney doctor. You can even use it for pediatric visits. We don't have any pediatric services in the county at this point. We've only been able to keep the clinic open by seeing a variety of patients. About 23% are Medicare, 18% are commercially insured, 10% are Medicaid. That leaves 48% who do not have insurance. We charge them $10 if they can afford it. If they can't, we don't turn anyone away. The only way we've been able to stay open is by seeing everyone, by using what the insured people can pay us so that we can take care of everyone. There needs to be some system where rural health care can be funded. We provide a lot of subsidy to the patients, both by underwriting the cost of their visit, underwriting their labs, and getting them free medicines. If we weren't able to do that, I don't know how patients would be able to get those things for themselves. Patients who have chronic health conditions need to be taken care of. When those conditions aren't taken care of, it becomes very dangerous for the person as well as very expensive for the system. We know rural health and rural health care are a mess. Clay County is not unique. All of rural Georgia has issues with poverty, transportation, and access to good health care. Your health shouldn't be determined by your zip code.
The state of Georgia is a growth state. People will come into business in the state of Georgia, and they won't honor this, and their people won't honor this. But it's got to be nearby. And when they look and see hospital closure, their chances of getting industry is The hospital is the economic engine.
Lieutenant Governor, Madam Chair, fellow committee members. As Dr. Kinsel said today, many Georgians like modern health care, largely because of their communities cannot support modern medicine. But entrenched poverty and access to specialists, medical technology, and facilities are also issues. Dr. Kinsel identified 3 major obstacles preventing her patients from having what she calls modern health care. These are property, transportation, access, but for our purpose, I call them healthcare bananas. Distance to care and access. While Dr. Kinsel and her clinic are not a hospital, the same applies to Georgia hospitals, especially our rural hospitals. Poverty and healthcare finance means not just a patient who cannot afford to see a practitioner, but also communities or whole regions of the state that cannot financially support a local healthcare facility or a practitioner. Without a patient mix to support a practitioner or a facility, no practitioners are likely to move in, nor new facilities built. As the payer mix in rural areas deteriorates, with large numbers of uninsured, healthcare finances become destabilized. 63 counties in Georgia do not have a pediatrician. 78 counties have no OBGYN. And half Georgia's 130,000 annual baby deliveries are in rural Georgia, where shortages of pediatricians and OBGYNs are acute. Those shortages are driven by the available patients and the payer mix that they represent. Dr. Kinsel talked in the video about how her patients pay for care at her clinic, and her payer mix is this: 23% Medicare, 18% commercially insured, 10% Medicaid, and 48% no insurance. This is how it works for most practitioners, facilities, and hospitals in rural Georgia. Certificate of need is the only tool that the state has to ensure geographic distribution of healthcare resources and to protect payer mix of existing practitioners and facilities to help ensure they stay open. When we talk about new facilities cherry-picking commercially insured patients, we're talking about the very delicate distribution of payer sources. Upsetting that mix for a hospital can send it into a financial death spiral. If a hospital is forced to cut back services or close, those patients whose payer mix drove the hospital under don't go away. They go to the next closest facility and weaken the next facility. The distance between a patient and the care they need is a major obstacle. The distance can be amplified by individual property. Traveling 30 to 40 miles for care might be inconvenienced if you own a car or can afford the gas. But for many in Clay County, the next closest practitioner might as well be the moon. Distance prevents some patients from receiving routine or preventative care. And when they finally go to the hospital, they're in far worse shape than those who are closer to care and who can afford early care. The National Institute reviewed the literature on how distance from care affects accessibility of health care. Lack of access to privately owned vehicles impacts healthcare access, not just in rural settings, but even in urban areas. For our most needed population, children and seniors, transportation proves a greater barrier. And unfortunately, veterans who have access to federal healthcare system also face obstacles in getting to their providers. Transportation can be a barrier to filling and refilling prescriptions, or getting follow-up care, or seeing professionals. Telehealth has probably the greatest potential to help close the physical distance separating patients in rural areas from modern healthcare. If the technology were available in clinics like Dr. Kinsel's, patients would have greater access to the specialists they need, and the difficulty and the expense of follow-up care can be dramatically reduced. While some are looking at the cost of expanding broadband, partly to increase telehealth, we also have to talk about how we pay the practitioner and who is on the other end of the connection. The third major challenge for rural hospital is preserving access to care. From the healthcare delivery system perspective, this means preserving certificate of need program. Much of the attention given to certificate of need concentrates on the idea of being a competitive tool between healthcare institutions. The fact of the matter is, certificate of need is the state's only tool for ensuring financially stable healthcare institutions with appropriate facilities located to serve Georgians' patients. We've spoken about the importance of the payer mix, the percentages of the commercially insured patient versus Medicaid, Medicare, and uninsured. Certificate of need gives the state a way of preserving a stable payer mix in existing facilities. If we remove the financial stability from our general hospitals, we could end up with only those facilities treating well-insured patients for lucrative procedures, while the entire population loses other important services like emergency departments. In rural areas where distance to care is a major problem for patients and the healthcare delivery system losing hospitals because their payer mix was picked will worsen the problem by increasing the distance to travel for care. Certificate of need is absolutely vital for retaining what remains of our rural healthcare network. Lieutenant Governor, thank you very much.
Is there any question where Monty Beasley stands on certificate of need? Next up is pleased to join today by Deb Watson, who is the Chief Information Officer at the Georgia Association for Primary Care.
Lieutenant Governor and members of this important task force, thank you so much for the opportunity to speak with you this morning. I send regrets from our Executive Director, Mr. Dwayne Hofka, as he's on the road traveling back from a national conference. But hopefully I can provide you an overview of what we do for our federally qualified health centers in the state and the Georgia Association. Again, we are the member organization for the federally qualified health centers in the state of Georgia, also known sometimes as community health centers. And, you know, our mission as an organization, or our members' mission, is to serve as basically a healthcare safety net in many areas of our communities. FQHCs, or federally qualified health centers, have been around for about 50 years. And over the last 15 years, we've actually doubled the footprint of the number of clinics and organizations that we have. Here in Georgia, we have 34 organizations, and these 34 organizations have 207 clinical sites in 111 counties in Georgia. And that includes some that are school-based health and some that are migrant health programs where we have a van pull up in the onion fields of Toombs County to provide health care. We have approximately about 2,500 staff members throughout the state. And our goal is to help serve those in rural areas and those with special needs get the health care that they need. Each health center basically maintains a very local focus on their needs because they each have and are directed by a board of directors that is local to their area, and 51% of those, as a minimum 51% of those board members have to be patients receiving services at our health centers. Our programs include not only primary care and preventative care, we also have women's health programs, pediatric programs, dental programs, some behavioral health, and some opportunities throughout different organizations to have discounted prescriptions. And although our organizations receive federal funding, we do depend heavily on Medicaid, Medicare, and insurance billing, as well as support of our local communities. Patients are offered a sliding fee scale based on their ability to pay, the number of folks in their family, and their income level. Over the next year, our focus, our push, our initiative is to increase partnerships with programs at hospitals, behavioral health organizations, and other referral specialists, to increase our implementation of health information exchange and utilize data analytics to better identify needs in areas, to adopt and implement more screening tools in order to try to more quickly identify the needs of our patients and make sure that either they're addressed or referred to other organizations that can assist in addressing those, and further our telehealth implementation so that we do enable patients to seek providers of other disciplines at our sites. So we're really got a big list of to-dos for this upcoming year, and our members are really behind this and try to get as much implementation as they can to increase the needs. We also want to partner more with the schools in order to get more students trained and get them into rural health centers. So I appreciate this opportunity to speak to you. Any questions? Thank you very much.
If any of you want to ask any questions, just give my attention to that. Also, please join me in welcoming Tom Andrews. Tom is the president and CEO of the St. Joseph Health System and president of Mercy Care as well. So thank you very much for your involvement.
Good morning. I too thank you, Lieutenant Governor and the task force, for allowing me to share the story of Mercy Care. Mercy Care is a community health center, a federally qualified health center. And unlike the other speakers, I'm getting older and I need cheat sheets, so I'm going to have a PowerPoint presentation for you. Let me start with a little history. Actually, Mercy Care is part of, or was part of a healthcare system called St. Joseph's Health System that was really the first hospital in Atlanta, built in 1880. It was the first hospital there, built right after the Civil War. In 1977, the hospital moved to the suburbs, and the Sisters of Mercy that started the hospital, as well as a lot of the doctors and nurses, felt like they had left their mission back downtown. So they created Mercy Care in the early 1980s to go back down to town to stay focused on their mission. We also have a program up here in Rome and have for over 35 years called Mercy Care Rome, which I'm going to talk about in a little bit as well. If I can use the carrier. So we are a federally qualified health center, but we are specifically funded as a healthcare for the homeless agency. So about 65% of the patients we serve are considered homeless. So this is a city snapshot of what Mercy Care focuses on every given day. On any given day in Atlanta, 4,000 people can experience homelessness, and over a period of a year, 20,000 can experience homelessness. Fulton County and DeKalb County have an uninsured rate of 17%. 39% of DeKalb residents and 34% of Fulton County residents live at or below 200% of the federal poverty guidelines. A while back, the philanthropic community did a study and looked at all the safety net providers in the greater Atlanta area and found that only about 35% of the residents living at 200% or below the federal poverty guidelines were actually accessing the safety net. So that begs the question, where are they going for care? Are they going to the emergency rooms, or are they going without care? Atlanta ranks 5th nationwide in newly diagnosed cases of HIV. And out of the 250,000 immigrants in Atlanta, 33% are unauthorized. These are our locations. We have 11 locations. 6 of these are full-service sites. The rest are satellite sites. We have 2 40-foot-long mobile coaches that we go and park in front of churches, outside of churches and food street kitchens to provide services to the underserved population. Very comprehensive in our approach to care. We started out with just basic primary care services, but over the years, as the needs of our patients increased, we created more and more services to respond to those needs. A lot of our patients, when they walk in the door, we don't know when we're going to see them next, so we try and do as much for them on that visit as we possibly can. So we have comprehensive primary care, preventative services, a lot of focus obviously around chronic diseases. About 6 years ago, we realized that about 60 to 70% of our patients had behavioral health issues, and we were not successful at referring those patients to mental health clinics. So Mercy Care went up and studied a model up in Knoxville, Tennessee, Cherokee Health Center, which is renowned for its integrated behavioral health program. And I'm proud to say that we now have integrated behavioral health available to all 100% of our patients in all of our 11 clinics. We've hired behavioral health specialists, professionals, psychiatrists, licensed clinical social workers, and every single patient, when they come into our door as a first-time patient, not only receives a health screening for their medical issues, but also their mental health issues. And we've even redesigned a lot of our clinics so that we have side-by-side the exam rooms, behavioral health counseling rooms, so there are warm handoffs from the medical providers to the behavioral health providers. And DBHDD has really helped us a lot trying to get this off the ground, because we do feel that it's a model that more and more primary care providers should be adopting, because it takes away the stigma of having people be referred to a mental health center. We also probably our highest demand is for dental services. In Atlanta, we don't have a dental school. So consequently, there are no providers for people who don't have dental insurance or cannot afford to pay for dental services. So that's our fastest, it has been our fastest growing program. And at 3 of our sites, we have people lining up at 5:30 in the morning to receive those services. We also have vision. We incorporate that in as our primary care base. And then we also have a Ryan White program, so we provide HIV primary care and a lot of work around HIV prevention. We also have a couple of unique outreach programs, because we think we have to go to where our patients are to make them connected, to get them connected to our services. So we have a street medicine program. They go out 4 nights a week. It's made up of 2 medical providers, a psychiatrist, and an MD, and then a whole array of support providers, including nurses, medical students from Emory and Morehouse. They go out on a coach, and they essentially go under the bridges, into the encampments, and they provide services right on the streets. I mean, we're talking full service, including drawing blood and providing medications. And it's been interesting as it's evolved over the last 4 years. We have routine clients we see every week at those locations. But the key is to get them connected to services broader than what we can offer on the street. So a lot of them, we've been successful getting them into our clinics. We also have a team that goes out during the day, including a nurse that does health screenings. And their job is to, once again, connect them to our clinics and provide services in a more appropriate setting. We have developed over the years what I think are the crucial parts of healthcare that are missing in many respects, and it's wraparound services, things that we really do need to offer to our patients in order to keep them healthy and keep them out of the emergency room and out of the hospital. We operate a recuperative care program, and it's where homeless individuals who are being released from the hospital can go and recuperate for up to 30 to 40 days while we keep them stable, keep them from being ridden into the hospital. And our goal is when they leave there, they're actually going to housing, not back to the streets and into shelters. And we have about a 71% success rate in using this recuperative care program for that purpose. We also have a lot of case managers that help our providers, because the providers can't do everything during a patient visit. So they hand off a lot of the social issues to our case managers. We also have care coordinators we've incorporated, and these individuals are really important to connect people to services when they're walking out our door. Specialty services, other health-related services that, again, our providers don't have the time to make that connection, so our care coordinators do that too. We've also just hired 2 community health workers that we're linking. The care coordinators are working with the patients to be linked to community health workers to, again, keep them stable in their homes and in their community. health education, family health promotion. We've added the pastoral care program, which has really gone over very, very well. And because we work with a lot with the homeless, we do have a lot of focus around housing support services. We have a lot of partnerships. We're basically joined at the hip with Grady. We would not be here without Grady. If you haven't heard that slogan, it's true for us as well. About 3 years ago, the most important step we made with Grady is we switched to the Epic healthcare system, a medical record system, which Grady is on, and a lot of the other hospital systems in Georgia or in Atlanta are on. We can now efficiently refer patients into the Grady system, and once they get into the Grady system, we can see what's happening with our patients. In the past, we used to have to refer patients who needed specialty services to the emergency department. Now they go directly to the specialist and come back to us. We also rely on other hospitals in the area. A lot of these other support services, housing and supportive services, are purely because of the nature of the patient population we serve. This is a breakdown of the work we did in 2016, about 53,000 office visits, close to 12,000 clinic patients, 26,000 medical visits, 9,000 mental health visits, dental, again, close behind, and then the case management, as I mentioned, really important wraparound. 66% of our patients were homeless, 83% were uninsured, and 83% lived at or below 100% of the federal poverty guidelines. Where our funding gaps are right now are in the area of dental. We only get funding, federal funding for dental, and the need is much greater than that. We get federal funding for primary care for our homeless patients, but not for our non-homeless patients. We do not currently have any steady stream for behavioral health funding. We serve about, as you saw, about 10,000 visits a year, over 3,000 patients, but we do not currently have any sustainable funding for those services. The recuperative care, we have 19 units. We figured in Atlanta we could use up to 75 units of post-hospitalization units that patients could recuperate in. We don't get much funding for health education, case management, care coordination, and community health workers. Mercy Care Rome, very special program here. Liz Molina, who's our executive director, is here with us today. They've been around for 35 years. And I call these preventative services because they really do help prevent and keep people healthy and keep them out of the hospital. We have an adult day health program, which is really a vitalizing program for seniors that are living in their homes. They can come and spend the day with us at Mercy Care Rome and receive medical oversight services and a lot of other support services. We also have caregiver support services. These cannot be underestimated. The caregivers in this community and all communities are the ones that really do keep the elderly healthy. If we support them, we can keep that population healthier and keep them, again, from using services unnecessarily. We have a Grants for Full Care program. Over 2.7 million grandparents are raising their grandkids across the country, and 1/5 of those live under the poverty line. Again, our support program is to support them in that hard work of raising their grandkids. We also have a really vital Title V program, senior employment program, and these are for seniors who find themselves in a situation of having to go back to work. And we have, last year alone, 44,000 hours of work by seniors in 2016 in nonprofit work settings. So the question I was asked to pose was, okay, this is what we do. What can we do to improve what we do, but do it in a way that's fiscally responsible? So the safety net providers, we feel, are crucial to access and decreasing costs of health care. How can we collectively do more for the uninsured population across our state, and how can we do it without breaking the bank? So what impacts good health? We talked about transportation, chronic illnesses, both physical and mental, disabilities, people who are disabled but are not on disability and can't access care, people who lack insurance, of course, the situation with HIV and AIDS, lack of housing or stable housing, substance abuse issues, as we talked about, shortage of providers, which we've talked about, mistrust of the system, historical patterns. In Georgia and in Atlanta specifically, we have found time and time again that generation after generation have gotten used to using emergency rooms for their routine care. And so that's just something that we've got to figure out how to break that trend. Poor oral health. Oral health and medical health are well connected. We all know that. If you don't take care of your oral health, it leads to medical issues and vice versa. Lack of access to healthy food, and then the overall health disparities that exist across our low-income populations. How can we increase access to basic healthcare services and improve outcomes? We've got to link people to medical homes. Mercy Care as well as a medical home in all 11 of our sites. And we've got to expand funding for community health centers to continue to expand the services they provide so they can be a medical home. Focus on the management of chronic disease. We've done this, but we haven't done it in a methodical way, and we haven't done it through automation by linking ourselves to hospitals so that we can make sure that we're, in fact, communicating and integrating the services. Improve, and that goes to improving on care coordination, increase availability of behavioral health services, and adopt this integrated approach. I swear to you, it is much more cost-effective and much better experience for the patient overall. Cover transportation costs, continue to focus on affordable housing and funding for appropriate supportive services. A lot of people we put into housing, we can't just drop them into housing and expect them to survive. They have to have wraparound services and supportive services like community health workers. Increase funding for the safety net to expand access to specialty services. We have a waiting line at Grady for getting patients into certain specialties, and it's because they just don't have enough of the specialists for the demand. Improve active access to dental care, and create funding mechanisms for more recuperative care and adult day health. How can we afford increased access to services and improve outcomes? We've got to transform our delivery systems. We cannot continue to operate with everybody in a silo. I've been in healthcare for 37 years, and it's been broken in all of those 37 years, and it's because everybody operates in a silo. Insurance companies, hospital providers, medical providers, the device manufacturers, the pharmaceutical companies. We've got to transform how we work with each other. And that's starting with the ACOs and some of the other payment system reforms, but we've got to really put the gas on in order to increase those efforts. And that comes to the next point, which is payment system reforms. We've got to really focus in that payment system reform on automation and integration of the care. And we've got to use evidence-based models. There's a lot of places across this country that have figured out what works best with high utilizers of the ED, what works best with getting people into medical homes, what incentives we need to use to get people to access services in the right location. And we need to look around the country. We've done that as well as Brady. And we've got some great ideas, but we've got to have the funding in order to implement those best practices. Community health workers, we've got to jump on this bandwagon. They are in many models across the country. They have saved so much for the healthcare delivery system because they keep people, healthy and safe and in their homes without getting out of control from a medical perspective. And then we've got to develop more intensive outpatient behavioral health models, as I mentioned. And I'm talking for those people that have real serious behavioral health issues. The Georgia situation is it's gotten better, but we've got to develop more outpatient intensive models to take care of those that have more serious issues associated with that. And then on the adult health side, these are programs that really are important, and we just don't have enough of them here in the state. And I would charge the task force with looking at adult day health and finding more and more ways to support those programs, because they really do help the senior citizens of our community who are frail, but could remain in their homes and stable for a much longer period of time if they had these resources. So I thank you to the task force. Good luck, and I love the opportunity to work with you further.
Yeah, I have a
We have some
question.
questions.
Just a comment and a question. First of all, I'm personally involved with Mercy Care Atlanta, and they do a great job, as do the other federally qualified health clinics. And obviously, you're based in Atlanta, and I'd like to know how that model can be implemented throughout the state.
I think we're unique in the sense that, I think somebody mentioned population health. Because we deal with a very vulnerable population, with the homeless population, we had to think about population health 20 years ago. So you see the array of services that we provide. It's principally because we have people with such need that we've had to create a delivery system that's very unique, and it is population health centric. So I would encourage other community health centers and primary care providers to think the way that we do. Look at the needs of the patients and create integrated services within your clinics to respond to all those needs, not just the medical problem of the day.
Can we recognize that individual from Mercy Care here in Rome?
Yes, it's Elizabeth Molina, and she's the executive director of Mercy Care Rome. If you haven't seen their facility, go out and visit. She would love to give you a tour.
You might have addressed this, but when we went with patients by the numbers, I was looking at those large figures on page patient about the numbers. I was just looking at those large numbers, 66% homeless, 83% uninsured, 83% below poverty line. How do y'all address that from a financial standpoint?
Well, about 70% of our funding, we operate a budget of about $21 million a year, and about 70% of that is covered through grants, mostly federal grants and some local state grants, thanks to Senator Unterman here. She actually sponsors or has sponsored funding for one of our homeless clinics. It's a patchwork of grants, and then the rest of it comes from fundraising. We're very fortunate to have a foundation. Mercy Care has grown to have a good reputation in the city with the foundations, the other philanthropic community. So we have to go out and raise the money to cover the rest of the costs associated with the services delivered. And I would say that to say that we're fortunately lucky, but if we found a way to create more funding for a lot of this, we would do more, and we would use that philanthropic opportunity to just add on to what we already do. So I just think we're very fortunate in that way, but most other community health centers and free clinics are not as fortunate as we are. Thank you very much.
Thank you, Tom. Excellent presentation. I'll call on Senator Hyman to introduce our next presenter.
Thank you, Governor. I appreciate it. I noticed that there were several nursing students that came in the room. Let's give them a round of applause. Schools here in Rome. There's Berry, there's Shorter, and there's Highland. Georgia Highlands. So we're delighted to have y'all here today, and we want you to graduate and go to work in the state of Georgia. Is that not right, Governor? So today we have with us a very distinguished visitor, Martha King, who is with the National Conference of State Legislatures. And Georgia was targeted when we got out of session this year in 2017 by several foundations, and in particular the U.S. Maternal and Child Health Bureau. And unfortunately, we were targeted not because we have good statistics, but because we have very poor statistics in infant mortality and maternal mortality and morbidity. So a special select team was chosen, and we traveled to Baltimore. And on that team, I was privileged to work with Senator Greg Kirk, Representative Pam Dickerson, Representative Beth Baskin, who drove up here. Governor, please acknowledge that. She drove all the way up here to visit with us in Rome. Dr. Brenda Fitzgerald, who was our commissioner at that time, but has now moved on. Diane Durrance, who is the Director of Women's Health, Maternal and Child Health in Georgia. Dr. Laura Jacobson, Director of Georgia's Health Promotions in the Department of Public Health. And Dr. Terry McFadden, the AAP Chapter Vice President, Emory Department of Pediatrics, and Vice President of Georgia's chapter of the American Academy of Pediatrics. So since we met in May, we have been continuing to work progressively all through the summer, all through the fall, and that's why we felt like it was very appropriate that we invited Ms. King. And she does get the award for traveling the furthest here from Denver, and she said it was colder here today and yesterday than it was in Denver. Welcome, Ms. King.
Lieutenant Governor, and the other distinguished senators, and these wonderful senators are all members of the National Conference of State Legislatures. Our membership is all 7,383 state legislators, and Georgia is our favorite state, just for the record. And I do want to say that I'm really impressed with Georgia and the dedication of your public officials, because this is actually the third time that I've had the privilege of being involved with a team of both legislators and executive branch officials from your wonderful Department of Public Health in terms of looking at key health issues. Senator Burke was on one of those projects that we had, and we did a follow-up meeting at the Capitol related to payment reform. We talked about community health workers. We talked about community services and so forth. So I want to commend Georgia for the excellent work that you all are doing, and your commitment here today just demonstrates that. And with all the people here, I'm just very impressed. And we'll take that news back to Denver and brag to the other states about it. In fact, we've been bragging about some of the initiatives in Georgia and some of the work that NCSL, the National Conference of State Legislatures, does. Even at a meeting that Georgia wasn't represented at a year and a half ago in California, we talked about your efforts to reduce preterm births. You worked with the Georgia Hospital Association and did that with a collaborative. You're using data to reduce infant mortality, and you've made substantial progress in that area by identifying clusters of high-risk areas and bringing intensive services in those areas, so congratulations on that. I also want to recognize a couple of our other members here. We've got Megan Andrews, who's with the Senate Research Office. Becky attended one of our meetings before, Becky Riles with Capital Consulting. Diane Durance is here. And Wayne Kafka was a member of the meeting that I talked about with the Primary Healthcare Association. So, as I say, Georgia's our favorite state. I just feel so privileged to be here. Actually, when Senator Edelman told me we were going to meet in Rome, I was dusting my passport out. And then she said, Rome, Georgia, and I said, that's even better. I actually grew up in rural Wyoming, and in Wyoming, I think Rome would be the third largest city if you were in Wyoming at this point. So thank you for your hospitality, and I've enjoyed my stay. I wish I could stay a little bit longer. I just want to mention before I introduce Dr. Laura Jacobson that several of the speakers here have talked about the importance of prevention and primary care, and it's really good that this task force is looking at that because half of our healthcare costs go to just 5% of the highest need folks. So if you can figure out who those folks are and give them the appropriate care in the appropriate place, as the former speaker just talked about, and get them back on track, you're doing an awful lot of good. But half of our population, the healthiest half, takes up only 3% of our healthcare costs. So much of that is to help keep them well. You've talked about some of the determinants to poverty. The Lieutenant Governor mentioned housing, employment, and safe places to live and work. If you can do the investments, and I know the Lieutenant Governor has been involved heavily in the Georgia Healthy Kids Initiative and the SHAPE project that you all have going. Investing in the health of your future generations of Georgians is one of the best investments that I think you can make. And Dr. Laura Jacobson is the Director of Health Promotion at the Department of Health, and she's got dozens of ideas. I should probably spend the rest of the afternoon talking about the different ideas in terms of what your excellent Department of Public Health folks can do with the initiatives and partnership with you. And she's going to talk about just one of the areas that we worked on with our team last and since May when we met in Baltimore. Thank you so much.
Thank you so much, Martha. Lieutenant Governor, Senator Underman, committee members, thank you so much. And good morning to every one of you out there. Martha is indeed correct that I could spend all day talking about moms and babies. I promise I won't, though. Today I'm going to be focusing in on moms and maternal mortality, but more importantly, what we can do in the path forward to help improve their health and decrease the number of women dying in childbirth or after childbirth. So let me start by introducing you to Lauren. This is Lauren Bloomstein. Some of you may have seen her face before. She's been featured in NPR. Lauren was a NICU nurse, and she was 33 years old when she became pregnant and was delighted to be starting her family with her husband. She gave birth full term by vaginal delivery to a beautiful little 5-pound, 12-ounce little girl. It was the happiest time of her life. Unfortunately, about 2 or 3 hours later, she started to have severe abdominal pain, and her blood pressure was creeping up by that point in time. Unfortunately, over the next 18 hours, things got worse, and eventually she had a cerebral hemorrhage or a bleed in her brain and died, leaving behind her husband and her brand new baby. Now, Lauren is not from Georgia, but she is the same story of many of the women we have here in Georgia that we look at on a very close basis to understand why it is that we have healthy women who are dying. So So the first thing I want to highlight is that our maternal deaths in the United States are unacceptably high. If you look on the left-hand side, what you see is a graph from the 1990s to now of how maternal mortality is changing. So the blue is the United States that you see rising up. And while there's a little bit of a dip, we know that since that time, there's still been an increase after that. And that's compared to the rest of the developed nations around the world. We are unacceptably high in maternal mortality. And as you heard earlier, Georgia is currently ranked 48th in maternal mortality. Now in 2013, we started to recognize that this was a very big problem. We wanted to do something about it as a state. At that time, the Georgia Maternal Mortality Review Committee, or the MMRC, was established to better understand why women are dying both during and after childbirth. And I'd like to thank Senator Burke for putting this into statute. So what is the MMRC? Well, it's a way of looking at why women are dying, what causes it, whether it's preventable. So the first step is identifying all possible deaths. So not only do we go to vital records to see women who may have died during childbirth or a year afterwards, our EPI team goes so far as to scour newspapers for obituaries to make sure we don't miss a single one. Then we gather medical information. I see some of our partners out there from the Georgia Obesity Society. They help us. It takes 20 hours to go through one woman's records to make sure we don't miss any of the details that are available. And then a group of multidisciplinary experts, so OB-gynecologists, pediatricians, NICU specialists, cardiologists, coroners, come together 4 times a year to look at every single one of these records and ask, was the death pregnancy related? Was it because of pregnancy? Are there common characteristics among these women? What were the causes of death? And finally, most importantly, was it preventable? And what could we do to prevent it? And after all this information is gathered, we go ahead and analyze it at the Department of Public Health. So what have we learned so far? We have about 2 years of data at this point in time, and we know that it can impact any pregnant mother in Georgia, regardless of age, regardless of socioeconomic status. Anyone can be at risk. However, we know that there are characteristics that make it more likely. For example, African American women have a higher rate of mortality. Women with low socioeconomic status also have a higher rate of mortality. The causes of death are quite simple and straightforward. One is hemorrhage. It takes 5 to 7 minutes after delivery for a woman to have a very, very serious hemorrhage, whether it's because her uterus isn't contracting, whether it's because she's had a rupture of her uterus. It is a medical emergency, and it's one that can be treated if it's recognized in a timely manner and also treated appropriately. High blood pressure, again, if that's recognized and treated early, negative consequences can be avoided. Cardiac problems, that's certainly increasing across the United States, where we see women who are dying up to a year after childbirth because of heart-related disease that started during pregnancy, embolism or clots that occur, and other forms of death. The most important thing I'd ask you to remember is that 50% of these deaths are preventable. So what are we going to do about it? Based on the information we have gathered, we are looking to implement patient safety bundles, and we've started down that path already. So why safety bundles? Well, first you have to recognize that every maternal death, it's just the tip of the iceberg. For every death, you have many more near misses, and that's what we need to prevent in order to decrease those numbers of death. So what are safety bundles? Well, they're hospital-based quality improvement tools. They're tools that improve the outcomes of things like hemorrhage and severe hypertension. They are protocols, policies, practice changes, and systems of tracking data. And they represent national consensus. So what does that mean in the real world for a hospital? That means that the hospital has the blood available that they need to treat a woman if she has a hemorrhage. They have protocols in place. They are measuring the amount of blood loss rather than just trying to estimate it visually. They have teams that have practiced. They have very clear safety protocols in place where after any adverse event occurs, they look at it very clearly to ask, what could we have done better? And thanks to the legislature who dedicated funding last year to start looking at maternal mortality, as well as the CDC, where we received a 5-year grant to improve quality improvement across the state for perinatal activities. we've started to establish a statewide infrastructure. So first of all, we have a lot of partners at the table, and I'd like to thank all of them. It includes the Georgia DCH, and Medicaid is the CMOs are at the table, the Georgia Hospital Association, GODS, many of the individual hospitals, ACOG, the AIM Alliance, the regional perinatal centers, and many individual hospitals. They've all come together and agreed that yes, we want these safety bundles, we want to do this quality improvement. So the second step is starting to implement those safety bundles. Now we've had a couple hospitals take some initial steps. We've got about a dozen hospitals on board to start this process in January. The third step will be to study, because anything we do, we need to make sure that we have that data available to understand if it's really decreasing those near misses that we talked about. So we have a system set up at this point in time where we can take this hospital discharge data, information that's already collected anyway, and start to analyze it and share it back with the hospitals so they know the progress they're making. And the fourth step, the step for the future, will be expanding to have more hospitals involved and to improve the process as we go. So what are our challenges and our opportunities? Well, we know that all change is local. We as a state can't come in and tell every hospital what their challenges are or how to do quality improvement. We can support it, but all those implementations have to be local. And we also understand that rural hospitals don't have the resources necessarily to do quality improvement. It often takes a dedicated personnel and additional resources, even though it can be cost-saving over time. So our opportunity with additional funding in the future would be to provide monitored grants to rural hospitals to help them implement these patient safety bundles as well in order to improve patient care quality. So I'd like to take just a moment to thank the team. We called ourselves Team Georgia, and I'm happy to answer any questions you may have. Thank you.
Just a quick question from a novice. When you're looking at the findings of the MMRC, do we have any kind of understanding how access or lack of access to a prenatal care may play a role?
That's an excellent question. We certainly know that lack of access to care, prenatal care, is a problem, and it is something that needs to be improved. However, it is important to remember that most women actually deliver in a hospital setting. So even if they have not received that prenatal care, there are opportunities to intervene once they enter the hospital, because most births are home births. There's certainly initiatives going to improve access to care in advance of those pregnancies, as well as between pregnancies, which is another key.
Can you identify regionally where most of these are occurring?
We know that it's throughout the state. There's not one area of cluster.
So,
From the standpoint of the barriers, I think we, as a committee, had several conversations about data and the fact that we're producing tons of it, but because of the different systems won't talk to each other, the left hand doesn't know what the right hand is doing. And how would you rank that from the standpoint of importance moving forward to lower some of these statistics? Is that ability for us to know more about what's going on in real time?
Thank you. I think that ability to share information across systems and to be able to analyze it in a very efficient manner is incredibly important. We're taking steps at DPH to have a coherent system that will help us with that. But the hope is with this system as well, using what already exists and being able to share that information back, it will be one step in that direction. But I agree, it's absolutely critical, and it's a challenging issue across all agencies.
very much. Next, I would like to welcome Dr. Scott Oakley from the Medical Association of Georgia as our next presenter.
Well, thank you. It's good to be here. My name is Scott Holting. I am a family physician in Brooklet, Georgia. That's not Brooklyn, New York. That's Brooklet, Georgia, which is a town of 1,200. Lieutenant Governor, I think you might know where that is. It's right outside of Statesboro, Georgia, which is outside of Savannah, Georgia. So it's my pleasure. I've been there going on 19 years now. Took over a practice since 1956. When I got there in 1999, we still had 5x7 index cards being used for our health records. I've since been to regular records and then now to an EMR since I've been there since 2002 and 2003. So it's been my pleasure to take care of folks in the Bullitt County area and the surrounding counties. What I'd like to address real briefly here today is for the physicians that are out there now that are working out in rural areas, the payment reform, as we discussed before, is paramount importance. It's tough to transition from a fee-for-service to value-based care and still be a viable option right now. So what do? Do we do the value-based? Do we do fee-for-service? We're in this transition time right now. It's very difficult with my patient population, which is very similar to the physician in Clay County, not quite to per extreme, but I have a large Medicare population. We have a large Medicare Medicaid, which we call the dual enrollment. Matter of fact, I think Bullitt County at one time had the most dual enrolled patients there. These are some of the most sickest patients that I see. Not only are they of age to be on Medicare, but this low socioeconomic class that they're in. These are patients that have multiple diagnoses. I don't get paid for anymore if I see them for one problem or I get for 14 problems. In the old days, we had 4 diagnoses that you could submit to Medicare to get paid. Now we have room for up to 14. I think the most we've done is 12 on one patient at one time. That is extraordinary to do in the limited time that we have to see the patients. I am in once again, a small town. I have no appointments. I'm a walk-in clinic. You come, you wait, we'll see you, as long as you come in at a certain time. I've done that. Dr. Bowler, the physician I took practice over, never had an ending time at the end of the day. He'd practice and 9 o'clock at night, be done, go home. Because he wanted and needed to see the patients. I think my personal best there is I saw 75 patients one day. I don't say that to impress you, I say that because of the need that is required there. Those folks need to see people. And it's very difficult in today's environment to do that. The next thing I'd like to, once again, talk about here would be what I call the hassle factor. It's prior approvals. I once had to get a prior approval on indomethacin, which is probably older than I am, and it's $4 at the local Walmart. It costs my staff time to get this prior approval, which is almost asinine in my opinion. We've been so encouraged to use generic medicines now. We do it. I get another example of doxycycline, use it all the time, but it's gone from $4 now to like $50 for a prescription of doxycycline. It's generic. Okay, so we have such issues with our patients getting payment for their medicines, the medicines they need, medicines they skip on many occasions and don't get them until the next day or two. That can be critical, especially if you have a serious infection. We have currently 4 CMOs that take care of the Medicaid folks. Each one has their own formulary. Each one has their different prior approval process. Each one has this, each one does that. As a walk-in clinic, I see patients come in to need a CT scan to rule out appendicitis, to rule out a head. They've been struck in the head and need to make sure they didn't have anything going on in their head. It requires almost a yeoman's work to get a CT scan approved through my office, through prior approval. Now, if they went to the emergency room, no such thing is necessary. They get taken care of. But I have so much saved the system, so much money by seeing the patients in my office. I've yet to hear anybody tell me how much money I've saved the system by seeing these patients in my office, not going to the emergency room, not going to the urgent care center, taking good care of diabetics so they don't go on dialysis and their high blood pressure and their heart disease and their cholesterol, taking such good care they don't have a heart attack, they don't need the cardiac catheterization. Nobody can quantify that to me, but I very much enjoy taking care of them and actually going home at night and saying, hey, I think I'm doing different, making a difference for taking care of these people. Just because you have insurance doesn't mean you have health care. We, in our area, see a very high deductible $1,500, $2,500, $5,000, $6,500 deductibles. So that prevents some people from coming in to be seen because they don't want to or can't afford those kind of deductibles. I would argue to you that I would love, if you are an employee of Coca-Cola or Delta or the city of Columbus, you have no charge to come in and see your primary care doctor or your primary care team. There's no charge. I would love to be able to do that for my folks, these insurance type plans. It doesn't cost them anything to come in. Because once again, me seeing them in the office is much cheaper than them going to the emergency room. And they're usually not as sick at that time because they're preventing their care, but letting it drag on, and then eventually they go to the hospital. And then that means probably admission to the hospital, and that's very expensive, as you well know. We had, at one time, in the exchange product, we had 2 exchange products. We had Blue Cross and Humana. Now we're down to 1. And last year, or this year, 2017, Blue Cross gave me a 30% reduction in my fees. We're seeing the same patients. And some of these are very sick patients too as well. It's tough to take a cut of 30% and still be a viable option. I am an independent practicing physician, been that way since I've been there. And I enjoy it. I'm my own boss, been doing it for, like I said, that 19 years, but I surely enjoy being able to take care of, I am the patient advocate. I'm not aligned by any employer or anything of that nature. When you're there, I'm your advocate. What can we do to help you take care of you? Now, I'd love for us to be able to do all these things that we talk about, but what about, and Ms. Hughes is going to speak from, I am a member of the Georgia Physician Board, and she's going to speak on how we're going to incentivize folks to physicians, nurse practitioners, PAs, dentists, to get them to rural areas. But I always want to stand up and raise my hand and say, how do we help folks that are out there now? How do we do that? It's a good question, and I don't completely have that answer. But as you see, the rural hospitals are closing. I actually moonlighted at one at Stuart Webster Hospital, which at one time was the poorest county in the state of Georgia. We used to cover that ER every weekend. I'd leave Columbus when I did my residency there, get there at 6 o'clock on Friday afternoon, and then left Monday morning at 6 a.m. The only reason we did that, we got paid minimal to do it, but the only physician out there, otherwise he would never have left town. So we'd go out there and work those 60 hours. Talking about, it's near and dear to my heart with these small hospitals. But let me throw this out there to everybody. When you have, if you're a physician coming out or education, the average debt now is $120,000 you come out of medical school. And you're going to go and you're going to try to work in these rural areas, and there's nobody to employ you. There's no rural hospital to employ you. It's tough to go out there and be almost nearly impossible to be a physician or anybody else to come out there and open up their own practice in a rural area. Because you have the patient population, the patient mix that we have, it's very difficult to sustain a practice. The other thing, right now, personally speaking right now, I'm an independent purchaser of my health insurance. 4 years ago, I have a high deductible HSA plan. My wife and 2 kids, it's $400 a month. It went to $800, went to $1,000, went to $1,400. Just got my premium notice for next year, $2,300. For myself, my wife, and 2 healthy kids. And that's an HSA. That's a $6,500 deductible and a $13,500, I believe, total deductible. So how is a young physician, independent, going to come out to that area and work and be able to be vital? It's very difficult, and I applaud the committee here for looking into this. But somebody who lives this every day, it's a very difficult thing. Now, I've gotten paid in cakes, corn. Dr. Sumner used to work in Wrightsville. She got paid, I'm sure, in lots of things. I wouldn't trade that for the world. They really are special patients. But it's very difficult to maintain a practice right now in this setting. Funny note on Mercer is that I applied to Mercer. I went to MCG, And they told me I didn't get in because they didn't think I was serious enough about going to a small area. A good friend of mine, who is a pediatric neurosurgeon in Greenville, South Carolina, got into Mercer, and I kid him to this day that I don't know how he did it and how I didn't be able to get in. But I was very blessed to be able to, I grew up in Jacksonville, Florida, went to University of Georgia at MCG, did my residency in Columbus, Georgia. I spent 4 years in the Air Force to pay for my medical school, otherwise I would have been in serious debt back then. But I enjoy every minute that I'm at in my little town, so I'll end that there too.
Yeah, I think you highlighted the last point you made, something really important, and that is if you as a physician can't afford individual health insurance for your family, welcome to the rest of Georgia who really can't afford their health insurance, and we're going to have to do something about that. On the prior authorization thing, my question was, do you have the same type of issues getting prior authorization for mental health services?
Well, I am the psychiatrist in my town. I am the nephrologist, the cardiologist, and so forth and so on. So the most difficult part in that, we have very limited access. Our closest is Savannah, which is about 50 miles away. It's actually getting the medicines. It's really difficult. Some of these medicines, once you use one, then you have to go through this stepwise approach, and that's very difficult for the patient. So it's mainly medicines that I see as the most difficult for the mental health.
Scott, do they offer you corn and hay for your psychology work?
Not yet, but I'm waiting for it.
I'm Air Force also, but just a quick question. Are you able to educate the patients to understand that it's less costly to go to the deductible route than to go to the emergency room?
Absolutely. In the old days, years ago, 10 or 15 years ago, I had a lot of patients, I still have a lot of patients who don't have any health insurance at all. Probably not as much as the position of Clay, but probably 20, 25, maybe 30%, a third of my population is probably self-pay. And I always told them to get, it's kind of crazy to go without any health insurance if you could afford a very high deductible plan at that time to prevent a catastrophe. If you could pay, it's a lot better to pay on $10,000 than it would be on a $100,000 hospital bill should they have an accident or need something of that nature. But the understanding now, the current, and some of the previous speakers have spoken to this, is that the mentality is we go to the emergency room. If you're sick, we go to the emergency room. And that's a very difficult thing to turn. I don't know how we do it. Like I said, I'd love to see it where they have incentivized to come see it probably here, out of the way. They don't, it doesn't cost for copay. Just like I said, if you work at Delta or something like that, it doesn't cost you to go see it coming here. So we'd love that.
Dr. Bogie, the impact and importance and the value of medical care, particularly in rural settings, is clearly demonstrated by your dedication. And I grew up in a household like you described. My dad making house calls until 10, 11 o'clock at night, being gone for 2 or 3 days at a time, us not seeing him. He was in a rural setting. He was an independent physician. He was taking care of the community. And I applaud you for your dedication to your patients, but equally important, I applaud you for your dedication and your service to your fellow man. Thank you very, very much. Thank you.
Every now and then Butch gets something right. I just wanted to make that same comment, but also to add to it the leadership you're showing. It is extremely difficult, as I'm well known to be active in a statewide role that you're in, trying to practice medicine and raise a family. And I just want to personally thank you for what you're doing.
I think what we're going to do is take a quick break, and we're a little bit behind schedule, but I think the lunch is prepared for us over to the side. So we'll take a break, ask you to go through the line, get your lunch, come back, and then we will resume in about 15 minutes. Task force back to order. And first of all, let me just express my appreciation allow each of you to know as well that, of course, the food was provided by Berry College, which absolutely did a remarkable job, and was paid for by Redmond and Floyd. So thank you very, very much. Let's give them a round of applause. Very hospitality. We're going to go ahead and resume our schedule. We're still a little bit behind, but we have some wonderful, wonderful presenters. And I am certainly happy to welcome Dr. Gerald Harmon, who is the chair of the American Medical Association Board of Trustees, to speak to primary care nationally. Thank you for traveling this long distance. Thank you, Gerald.
Good morning. Thank you. Actually, I'm going to have to readjust that. If I were in Denver, it would be more. Good afternoon. Anyway, I want to thank you for the opportunity to be here on behalf of the American Medical Association. This is an exciting task force to be presenting and discussing today. I thank you. I want to express a special thanks to Lieutenant Governor Cape. Thank you. Senator Huckstep. Thank you. Thanks for the invitation this morning. President Briggs. I'm going to tell you about President Briggs. We had a discussion. You know, we are in Rome, Georgia. We've got unsweet tea. You know, even in Chicago, if you go to McDonald's, you get sweet tea. Just got to remind the judge. He said, "But we're here for public health and preventive measures, so I can't really endorse sweet tea." And I said, "Well, just give us an option, maybe take a little bit of it." But anyway, thank you, President Briggs. Also, Chairman Humphrey, thank you for your leadership at Health and Human Services. Thanks to the Medical Society of Georgia. Dr. Scott Polkey is a family doctor. Mom and Ilk, I'll tell you a little bit about our similarities in a minute. In fact, let me give you some background. I introduced myself as a country doctor. I'm a family physician in small town, South Carolina, in Georgetown County. We have a 100-bed hospital. I'm still practicing. I admit to the hospital to take call. I made rounds yesterday. When I get home this evening, I'll be on call. And tomorrow morning, I'll be making rounds for the week. I'm in an office with 4 other physicians, an advanced practice nurse that I helped train. He's been my colleague and friend for 18 years now. We take care of the same kind of patient population that you heard from Dr. Volke. I have been paid in corn. I've been paid, I haven't been paid in hay yet. I've been paid in shrimp. Or I come out back in my truck sometimes, a little note says, "Doc, look in the bed of your truck, there's 3 watermelons in it." And I clearly share those with my office members and my colleagues, but I think the best one, the lightest one, I take it home. When I first started practice a long time ago, and it's decades ago now, when I first started practice, I actually got paid in a string of flounder. I came in the back door and started to swim with flounder, and I thought it was great, but then I thought about this. I haven't really been paid very well, because now I've got to clean scale these fish, and I had to lay down some kind of reasonable rules. You need to clean the fish before you land. Bring them in. And I really prefer the frozen shrimp or the fresh shrimp in the cooler. So I don't have to have them and all the other things. But I will tell you, that's the life we do in primary care. Y'all have experienced it, many of you grown up in that community. I want to tell you real briefly, too. I know we're behind, so I'll make a quick other remarks. I actually went to school in the 8th grade in nearby Calhoun, Georgia. I'm from Newberry, South Carolina. I was in the textile industry. We used to have a cotton mill. We may still have one in Calhoun. I haven't been there in 50 years. But in the 8th grade, I was in Calhoun, Georgia. Before that, I was 2 years in Atlanta. I was in Atlanta when the Braves moved to Atlanta. I wanted to go to Georgia Tech as an engineer. I was a dedicated Georgia, studied Georgia history and everything, so I'm a relocated former Georgia resident. Still a Tech and a Bulldog fan, although I'm a committed almost violent Gamecock. I trust the Gamecocks. My kids are all Gamecocks. My wife is a BSN nurse graduate from the University of South Carolina. I'm in a private practice. I'm school nurse coordinator. I work with the school district. I run a medical hospice, a not-for-profit volunteers hospice medical director. I go to nursing homes. I think I'm a full-spectrum family doctor. I used to do obstetrics, but I don't do that anymore. I'm a 35-year veteran of the Armed Forces. I went to medical school, I did Scott, Air Force scholarship. On the after I paid for that, I stuck around and retired from the Air Force about 10 years ago. So, Senator Dr. King and the Air Force veterans, thank you. Thank all of you for doing that. As we approach Veterans Day, I'm very mindful of my veterans experience and my military experience. I'm honored to be a part of that. tell you, people often ask me, if I'm so busy, why am I chairman of the board of the American Medical Association? Well, I found in my enthusiasm to be a primary care doctor, there's only so many people you can touch with one stethoscope. But if you get to that level of leadership in the AMA and national leadership, you can have an impact. You can testify before Health and Human Services secretaries, the Office of Civil Rights, telling them what a HIPAA audit does and how it impacts my patient population. I was at Washington Thursday, in fact, listening to Seema Vernon, CMS administrator. They asked me, as chairman of the AMA, what she can do personally, sort of legislative relief, to relieve me of some of the burdens. And you heard Scott Balke say prior authorizations. I gave her some ideas. What we're hearing today is a whole litany of challenges and problems for obstetrical access, primary care access, for closure of hospitals, but very few answers. Our challenge, and your task force is doing that today, is come up with survival answers that potentially operate and not just ideas, that are products and not just promises. So I'll tell you what the AMA is doing. I answered briefly any questions, but I'll try to get off the dais and let the other speakers get on with it. AMA, what is AMA? Why don't you think, well, it's this big nebulous organization up in Chicago? Well, it represents almost 190 special societies and state societies like Georgia, like South Carolina, orthopedic hand surgeons, like Senator Kirkpatrick, family doctors like me and Dr. Balke, psychiatrists, if you can find them, dermatologists, hospital administrators. We represent doctors who are administrators, we represent deans of medical schools, researchers, folks like Dr. Bender Fitzgerald, who's now CDC director, used to be the public health commissioner in Atlanta. So we really represent the entire spectrum of medicine. I can't recall a time when there was more uncertainty about our health care infrastructure in this country. So at this moment, we can either be discouraged or inspired. And I choose the latter. I'm inspired. I think now's the time to be a leader in medicine. Now's the time to be a leader in healthcare. Every venue, every aspect. Now it's important on us to get it right. What are we doing at the AMA? We have three overarching strategic arcs. We have tools for the field, which we talk about physician satisfaction, practice sustainability, accelerating change in medical education, which includes medical school, pre-medical school, and postgraduate medical education, and chronic care, improving health outcomes, with an emphasis on diabetes, cardiovascular disease, and opioids. We're trying to reshape the healthcare landscape. We're working nationally. You remember when President Obama was the president, he told us this is going to hurt. I'm surprised he did. When President Trump got in there, he said, hey, we'll fix this healthcare, it won't hurt a bit. Now his famous quote, and I'm used to bring to audiences now, is, who knew healthcare could be so complicated? I bet the folks in this room knew it was complicated. You bet your banana. Now, what are we going to do? We have a whole bunch of issues. You know, the biggest thing we hear about right now, front and center, is the issue of CSR, which stands for customer service we have to do in the banking industry. It stands for cost share reductions. And it's this 7 million Americans that cannot afford their co-payments or deductibles under the Affordable Care Act exchange plans. Those are the folks that are probably at 200, 250% or lower the federal poverty level that really have the hardest impact coming up with $10 co-payment or the $3 office visit deductible. And the CSRs are paid directly by the federal government right now to the insurance companies to make up for that gap so that these folks can get their care. Right now, though, if you don't do that, then that's been evaded, that's been held recently by the federal government because it's very complicated, but the Supreme Court said it's not part of the legislation that was funded. So the economics decision not to fund the CSRs has probably raised our front premiums anywhere from 15 to 38%. So there's an underwritten problem now that we're kind of penalized and pound foolish. That's the biggest issue. We need to stabilize the current health care situation in health insurance. Let's talk about what's going on locally. We're talking about primary care here in Georgia. I'm a primary care specialist. During my wheelhouse. There's a workforce mapper that American Medical Association can make available to Georgia. In Georgia, I think MAG, Medical Association of Georgia, has access to mine. You've got my contact information, I can give it to you. You can use this, and it's an interactive geographic map, and I'm not going to try to show you because it will take too long. But I can drill down and know that Georgia has, right now, probably 20 counties that either have one primary care provider, or minimum, 20 counties and 10 million people in the state of Georgia. 9 of them don't have any health care providers, primary care providers. 11 only have one. Our APRN folks, I sat down and talked with them a little bit. Dean Marion, this is one of our heart. And that's an opportunity for us to expand our workforce, primary care workforce, something we can do. We need to have physicians and our advanced practitioners help us with that. Primary care is begging for need, our patients are begging for it. One of the things we're finding is our primary care doctors, and you heard Dr. Bulk, and you've seen it, and other folks, we're getting tired. We're getting worn out. Now, we're not, I don't like doctors that whine. I don't like providers that whine. I just think it's normal though to take care of them, because it's hard to take care of the population, to do these incredible jobs of sacrifice, to work 2 or 3 days at a time, to make house calls, to get paid, if you get paid at all, in shrimp, corn, hay. I mean, I don't want to shortchange our providers, but if we shortchange them, we shortchange our patients. They've got to stay in business. Hospitals have to stay open. You heard about access issues. But the AMA is looking for somehow taking the burnout episode. You heard Dr. Bolton talk about prior authorizations. We've done studies that show that the average physician in practice today is spending the office is spending 16 full-time hours a week to take care of prior authorization per provider. In my office, I've got 5 providers, so that means I've got 80 hours a week they spend on me. But I call administrative crud. You know, it doesn't add any value, it just limits access to care. So the AMA has opportunities. One of the things I talked with the HHS and the CMS secretary last week was ways to, they can handle administratively reduction in this. We already got our medicine they've been taking. He mentioned 1 or 2 like doxycycline, certain blood pressure pills. If the patient's been on it 4 or 5 years and stable, no way in heck should I have to have paperwork to reauthorize these cures just because the insurance plan changed. This is October. The new plan's going to be in place. I guarantee when I get back to my practice tomorrow, I'm going to see reams of paperwork and faxes saying, reauthorize, reauthorize. There's no value in that. The value is in allowing the patient to continue actively taking their medicine. Because if there's a gap in care, they're going to have heart attack, stroke, infection, all the things we don't need to be paying for as taxpayers, or the patient needs to be paying for with their health. These things can be improved upon. Electronic records. Everybody knows what we call EMRs. We ask doctors what's your most common complaint, well, 54 to 64% of them, that's almost 2/3, say, I hate my computer. Try to take it away from them, they don't want to change it. They want to go back to paper. But they hate their computers because they're looking at the computer all the time, and the patient's over here. So you have a hard time listening to your patient. In my practice, my administrators, my nurses get mad at me because I'm going to take the computer in the room. I take a little piece of paper. I find myself in the room without a piece of paper, I write on a paper towel. I take a message, I take notes when I'm looking my patient in the eye, when I'm listening to them, and I'm taking what they're taking to heart. And I'm writing it down. I go outside and I work 6 hours a day on average, which is what the statistics show, pointing and clicking and doing scribe work to make decisions to meet the government requirements. Those medical records need to be easier. I need to have a better way to do it. We need to take that burden away. Writing up the medical records is like a Tower of Babel. One electronic record won't talk to another. Even though the federal requirements are there, the feds don't enforce it, and the vendors get away with not having to do it. It just drives us in practice real crazy. We talked about this. Let me talk about real quickly chronic care. This is my wheelhouse. If we don't improve the chronic care problem in the country, especially diabetes, especially cardiovascular disease, we're not going to get to it. One of the reasons we're having this discussion is an increasing burden of need with a lowered, or actually limited resource. You can't continue to have an increasing demand on limited resources. There has to be some adjustment. We have to bend that cost curve. Diabetes right now, cardiovascular disease, cost about $800 billion in a $3 trillion system. 3/4 of the patients to come to my practice are chronic disease patients. If I can address those burdens of chronic care, then I can make a difference. What's the AMA done about it? We've partnered. We have partnered with the CDC and with the American Heart Association to address blood pressure, which is the #1 cause of cardiovascular disease. You've got to control blood pressure. You've got to make your patients be able to afford to take their medications. To address diabetes, I'm one of 3 practices in South Carolina that's participating in the diabetes prevention program. Diabetes, 80% of the people who have pre-diabetes or who get diabetes don't even know they have it. They don't know, the doctors don't screen for it, the providers don't screen for it, because we're not paid to screen for a disease that doesn't exist yet. We have managed to talk to Health and Human Services and CMS that in April of next year, April 2018, screening for prediabetes, which allows us to prevent the progression to diabetes, will now be paid for. So if I do testing, if I bring the patient in, if I educate them and talk to them about it, not a preventive medicine visit, a real visit for a real disease called prediabetes, I'm allowed to get paid to do that, and they're allowed to have their insurance company pay for it, not have co-payments and deductibles and not allowed visits. That's a big issue to me. We're making efforts. I get to do that by talking to Congress and saying, pay for this common sense thing. And I take the gravitas of the practicing family doc into the testimony room and into the committee, and they'll listen to me. Not that they won't listen to researchers, Dr. Jacobson from Stanford and Harvard, but it sure has better impact if I come in as a country doc. It really does. Opioids. Over 90 people are dying every day from opioids. We have an opioid task force at AMA. It's chaired by Patrice Harris, psychiatrist from Atlanta. Patrice is still the chairperson of our task force. We'll tell you that we know opioids are a big deal. We've already reduced the number of prescriptions written by providers, by physicians in the United States. We reduced that by 20%, hopefully 10% every year. We've increased the numbers of checking the prescription drug monitoring program, which allows us to look for the use of opioids. We've increased that use by 800%. Many states now require that to happen. I'm not sure what Georgia's legislative effort. South Carolina requires me before I like a Schedule II, such as oxycodone or hydrocodone. I've got to check this thing to make sure that person's not a hidden or unaware drug abuser. They may be getting more medicines. They think they're treating a disease, but they're really increasing the supply of opioids. I'll also comment, and you also know this too, that the most common cause of death right now is not prescription drugs. It's the illicit fentanyl, which is the new manufactured drug, or straight old heroin. Some people are going straight to heroin. One of the things that are causing this, there's just not enough psychiatrists. You know, we don't have these substance abuse disease diagnoses need to be managed by psychiatrists. And one of the things we talk about is there's no psychiatrists in our communities. In my county, we have 0 registered psychiatrists. None. So not only do we have primary care, mental health care access is virtually non-existent. We need to help that issue. So we're trying to work well with our medical schools to produce more psychiatrists, to increase graduate medical education opportunities. Big deal. We talk about digital solutions for doctors. You think doctors hate the electronic records. If you take the studies, actually about half of them would embrace more digital solutions because it makes their lives easier. They just need better tools to get these digital solutions. So, you know, it's hard to push somebody where they don't want to go. But if you make it more attractive and easier, our physicians will use these digital solutions. Redesign our primary care workforce. We're working hard on that. All of us like to. We're looking at medical homes. We're expanding physician-led primary care teams. We believe in that. Use of our advanced practice nurses. Increasing use of our physician assistants. When I talk about training our medical education system and changing it, I have 3 new doctors that have joined me in the last 5 years. They weren't trained in medical school to work in a primary care physician-led. They didn't even have, I bring in and I have the advanced practice nurse and physician assistant. I ask my colleagues, I say, help these, my colleagues, my APRN and my physician assistant, look at x-rays, do this. And they say, we weren't trained to work in a team-based environment. Shame on us for not doing that. We have now changed in 32 medical schools in the country. The AMA has invested $22 million in these 32 medical schools to change the way we're training these doctors. They're working in teams. They work with pharmacists. They work with nurse practitioners, physician assistants. They need to understand that they're part of the team. Now, we're encouraging them to take ownership and captaincy of it, but they need to be trained to be part of the team. That's another issue we can do. We're working hard on that. We use telemedicine. I know this is a telemedicine activity. The AMA supports telemedicine. I have a telemedicine practice. We use telepsychiatry in my practice. We use telepharmacology and telepediatrics. I have an upstairs room dedicated just for this one, kind of an advanced Skype, but it's beyond Skype technology. If you want to relax the use of telemedicine, use rules, legislative efforts, we've got a sample state telemedicine act that we can provide to your state legislature. Madam Chair, anytime that allows us regulatory relief and allows us to get compensated pay, yet still be accountable for telemedicine. You've got to be accountable to quality care. We support the Connect for Health Act. We think, if you look at it, it incorporates AMA safety standards and quality into federal regulations also. But we're encouraged that all of our state legislators need to have a hand in this. Our state insurance commission need to have local authority not be subjected to federal authority. The federal authority needs to give it to our states. This is Georgia, this is South Carolina after all. We want to be independent. We want to be in a large organization. This needs to be Georgia specific, South Carolina specific, Colorado specific, whatever it has to be. The state needs to have ownership of the quality and regulation. I'll leave real quickly. We may not have time for questions. Tom Frist, Lake Center, former Tom Frist, former Senator Frist, he quoted something I still remember. Take care of the patient, and everything else will follow. I live by that mantra. I hope all of us will in this task force. Thank you.
Yes.
Is it on? We appreciate you coming to Georgia. My question, there was an article in Politico magazine, not magazine, newspaper, blog, whatever you want to call it. Always take it with a grain of salt because a lot of it is, that's right, and that's the title of it. But one of the articles was about physician salaries, and I was just wondering if you could tell me across the United States, what is a primary care physician? Not necessarily an internist, but a primary care physician, what's the average salary?
Madam Chairman, that's a good question. It's at the bottom of the salary total, is what it is. The very bottom is pediatricians. Dr. Jacobson will probably confirm that. Right now, we're offering in our practice, in our community, right at $148,000, which is a six-figure salary. You think, goodness, that's got to be a lot. But it really turns out to be about $78 an hour, if you think about it. What the amount of work there is.
So that's, is that a pediatrician or is that a?
General practitioner is $168,000.
For across the United States, is that the average?
I can only stick to that. I think the average is in that general ballpark. So if it's an attractive number. I mean, it sounds good, but if you talk about the debt that you burden yourself with from medical school, Dr. Volke said 120,000. Actually, the AMA statistics show 187,000. Is the average medical school graduate.
And they quoted 200,000.
Well, that's probably close. It depends on which one, Senator, but it is aggravating. It's above, though, certainly what my daddy made when he was in cotton mills and what many of y'all made when you were in cotton mills. But if you look at it, $70 to $80 an hour is probably competitive with someone with 12 years of education post-high school. 24 years of formal education. These practitioners with the sashes will tell you they have years of formal education too. If you're going to get paid $78 an hour, probably not unreasonable. The challenge is we really don't have a return on that investment with our primary care folks. We still are spending more per capita and we're trying to have a better quality outcome. I think that's what we're doing.
I just wanted to second what you said about team-based care. I think in the patient safety world, which I've done some work on in the operating room, we have to have all hands on deck, and we have to have everybody communicating and everybody feeling empowered to speak up and to be part of the safety process. Thank you for bringing that up.
And certainly, if you see something, it's almost like the TSA and the Homeland Security issue. If you see something, say something. If you see a patient's room that's got some IVs that are beeping or not hanging, change it. If you see a patient eating something that's about to fall out of the bed, change it. Senator.
One other question. The telepsychiatry program we talk about, I know we've got a huge shortage of psychiatrists in our state. Yours is probably the same. How long has that been going on over there? Any more elaboration on the good and the bad of it?
Well, yes, sir, the good and the bad and the ugly of psychiatry and mental health is probably because it is economic. You heard Joe Hunterman talk about the economic psychiatrists have really not been compensated. There's a thing called parity, mental health parity. The psychiatrists and mental health professionals are limited by the insurance plans, even though the procedures by the insurance companies are to pay for hip replacement and surgery, diagnostic intervention, when I do an EKG or take care of somebody in the office, to sit and talk to them and figure out what's going on. It's not well compensated. And if I put down on my counterform depression or stress or anxiety, their insurance plans may not cover mental health, except for say 3 to 4 visits. So I have to almost parse out when I'm diagnosing and submitting as a diagnosis. So people tend to vote with their feet. If they see irregularities, if they see low compensation, they're gonna vote to do something. They're gonna vote to go into research, institutional-based, psychiatric, mental health. They're not going to community basis, so it's a challenge there, sir. It's been going on, as you know, too, many states, and I'm not sure what we have here, many states are closing inpatient psychiatry facilities. So inpatient mental health facilities are closed, there's no place for these folks to work. Again, it seems to be a cost-saving measure, because most of those may have been run by state and or federal funds, and it's a budgetary restriction. But it's something that has left us now with an increasing population of ambulatory mental health patients, and no place for them to receive treatment.
Thank you.
One quick question. For the
behind.
your partnership to prevent chronic disease.
Yes, sir.
Could you talk a little bit about your community outreach? I guess you would say to educate people about the correlation between
Senator.
etc.
Absolutely. What we're trying to do is educate. I mentioned that 80% of the 80 million South Americans who have prediabetes, which is an A1C above 6.1, fasting blood sugar above 120, if I recall the numbers. I'm not a researcher, so forgive me. But that kind of number, they're at high risk for developing diabetes. We just need to improve the access to diagnostic and awareness to these folks. And if we have diabetes prevention programs scattered throughout the nation, and especially in our rural areas, we can encourage them to treat and take preventive measures to lose weight, exercise, even take medication to lower their diabetes risk, lowering their weight, increasing their cardiovascular capabilities, lowering their blood pressure, and lowering their blood sugar. So it's an educational process. We have to spend, education is why we're here today, educate all of them. Thanks.
Quick question. I know you're used to having a hook around my neck. I just want to ask you a quick question about telemedicine. On the revenue stream of the provider that is sending the information, and then you have the provider receiving it and reading it. And have you done any studies across the United States about CPT codes? Because that seems to be our biggest hang-up. There's 2 people that need to be paid. And have you done any of those studies?
Well, I'm going to have to dig in my repository. There are CPT codes that the insurance providers, including CMS, Center for Medicare and Medicaid Services, there are codes that are now existent for telehealth and telemedicine. They're just not paid.
Right.
Yeah, that's the challenge. They're not paid. And I think that the point is, as long as a doctor, as long as there's someone accountable for that, so that we're not just taking advantage of either the payer or the patient and using what we call digital snake oil, or I have a website that talktomeboutyoureheadache.com, and I listen to them electronically, send them some prescription, and I may be even outside the territory of the United States, because the internet don't know where I am. If I can't be held accountable by the Georgia State Board of Medical Examiners and Georgia State Legislature and Insurance Commission, and that's our concern. There needs to be an established relationship with the provider and the patient. If you're doing telehealth validly, I might be doing telehealth, sending an email to one of my patients in Georgetown, South Carolina now, and eventually I might get paid for that if I'm using my time. But I'm accountable to the State Board of South Carolina, or in Georgia if I'm practicing in Georgia, no matter where I might be. That's the issues we haven't figured out.
Wonderful. Thank you so much.
I gotta go.
Yeah.
Not that I need to do, I need to get other people.
Thank you so much. I appreciate that. Let's give him a round of applause. I'm going to need that round of applause after Saturday when Georgia puts it on South Carolina. Please join me in welcoming LaShawn Hughes, Executive Director of the Georgia Board of Physician Workers.
Thank you, Lieutenant Governor. Thank you, committee members, for allowing me to speak about the Georgia Board of Physician Workforce. I had a brief presentation, but I'd like to leave time for Donna Sumner, who's here with me to talk about our data collection. Here's information on our medical school enrollment. We have 2,797 students enrolled here. 2,060 are from Georgia. And our hope is that when they graduate from medical school and complete their residency, they'll stay with us in Georgia and hopefully practice in rural Georgia as well. We have new programs receiving funding from our board. There's 2,741 residency slots here. We only have 2,406 currently filled. That's because some of these programs are ramping up, starting up every year, and happy to report that 4 of those for this year will be in psychiatry, which will make us have 8 for since last year. So we are hearing the concerns. The hospitals are starting, so Coliseum will have 8 residency slots coming up. How does the workforce board help? We have positions for rural areas long repayment. There's been a lot of discussion about the debt that positions encounter. So we surveyed residents when they leave school. They're required to do it. And out of 355 for last year, we had 55 that had debt of $350,000. That is substantial debt compared to what you just heard about salaries. And these are for physicians that are practicing that went to school here in Georgia. How do we help with that? We have a loan repayment program, and our map shows the counties that we think, based on the population and other concerns that we have, that would qualify for a loan repayment program. It's a lot of counties that need the help. You can tell the Metro Atlanta area, if you're fortunate enough to live in Metro Atlanta, then you have health care, you have access to health care. But some of the other areas, you're poorly lacking health care. So the last time I went out and talked about how we decide how people get a loan repayment. You learn a lot after your presentations. So the board ranks our applicants based on the county that they're going to practice in. It has to be one of our qualifying counties. How much debt they have. How much the county ranking. We look at the county ranking from a website to see what in this county, how you're ranked, how your county is ranked. And we put all of that together and we rank the people that get our loan repayments based on their total score. So more information that someone asked me the last time I did my presentation. This is a map of all loan repayment program recipients in 2017. It shows exactly where we have put our loan repayments, where people are practicing. We have 47 counties represented, 43 physicians are practicing, 8 dentists, 10 APRNs, and 10 PAs. So some policy proposals that we've learned by talking to people outside is we need to increase the number of recipients for our loan repayment program. We're very thankful to the legislature for giving us funding for it. We will be happy to take any additional funding that anyone else asks for or give to the board. We have learned from the medical schools and the AHECs that we need to create a pipeline program to connect rural, middle, and high school with medical schools and medical professionals. I spoke to a group in Callaway Garden recently, and a lady at the desk said, I want to be a nurse. How can you help me become a nurse or a healthcare practitioner? Well, the AHECs was there. This is something that they do all the time, so I connected those two people together. It's about learning what's out there and helping high school students, middle school students connect to these. We need to expand the amount of slots at our current GME programs. This year, we've expanded to 109 additional slots. We need to develop new GME programs. How do we get our community involved? And so I've gotten this from some of this from Dr. Sumner from Mercer, some other community involved people. I have a board member who worked off a service cancelable loan in a small community. Her husband gave me some suggestions. We need to mentor again on our high school students. We need to partner with our medical, nursing, PA schools again to help the middle and high school students. We need to work with our community leaders from various institutions. If you're fortunate enough to get a physician to come in your community, you know, someone should be there to say, this is the church we go to, how about going with us? You know, take them around to the hospital, the schools, show them the schools, have your bank partner with them to build an infrastructure around your new community, new physician. A lot of these young physicians say, I have two daughters, and they say, I don't know anybody, so I don't want to go into that community, or I don't want to go to this. Well, some of the medical students feel the same way. They come into your community and they don't know anybody. They don't know anybody around to take them around. So make sure you put an infrastructure around these medical students and work with your local industries to make sure that the impact that physicians have in your community. It would be great if you have a rural community and your physician was there, the health plan, if there is a health plan in that community, make sure that that physician is on your panel. We have practice opportunity fairs to match residents with hospitals in rural areas. And I gave the committee a packet of information that we hand out to the residents. So we put a map of Georgia up, and we put this county and what the hospitals are looking for, some areas of interest in there. So they have the opportunity to go around, meet with the hospitals, talk to them, and hopefully follow up with that. We just had a fair at Augusta University, and we had 78 residents that came through. We had 27 exhibitors, which are hospitals and practices in rural areas. So that is one thing that the board is trying to do, to get people aware, to get residents aware, and get the community out to meet some of these folks. We produce data. That's a big part of what we do. We survey everyone. And we do an annual report. We do the graduate medical school exit survey, medical school graduate survey. We do medical school fact sheets. We do reports on where physicians are practicing. We're thankful to the Board of Nursing for providing us with information about where nurses, APRNs are practicing in the state of Georgia. I'd like to acknowledge Dean Marion. She is a consultant to the Board of Physician Workforce for our APRN loan repayment program. As an APRN, since nursing students are here, if you promise to work in a rural area, we can give you $10,000 a year, up to $40,000 a year for every $10,000 every year served to pay back their loans. So Dean Marion has been helpful with us with that. Same thing for PAs. We get $10,000 a year. We get $25,000 a year for physicians and $25,000 for dentists as well. So with that, I am introducing Donna Sumner, I spelled her name wrong. She's going to talk more about the data visualization project that the board is working on, and then we'll answer questions.
Thank you, Sharon, and thank you for having me today to talk about data after lunch. So, sorry, the IT person comes up to talk about data after lunch, but you're actually going to see that this is very exciting. This is something that we're thrilled to be a part of. Data collection, but made consumable for everyone to be able to understand what's going on in our state. So, oh, my presentation has gone. Let's see. Let me get it back. Bear with me. Oh, there it is. Okay, I think we're good. Sorry, everybody. It's not working. Let's see if we can figure this out.
So how about those Bulldogs, guys?
This is good stuff, so I'll go through and have some notes. So I'll tell you just kind of a high level of what I wanted to talk to you all today, and then it looks like we can show you the important things. So that's good. So I wanted to talk to you a little bit about the work that we have done. I work with the Georgia Technology Authority, and our team has partnered with LaSharn's team to take the data that they're collecting on the license renewal cycles and make it consumable and make it actionable and make it something that can be easily used to help and support the mission. So we talk about what that is, but why are we doing that? Because data has no value at all if you can't consume it and then communicate it. Rows and columns are very unfriendly. You can have several pages stacked up with rows and columns talking about all of the deficits of physicians in rural Georgia, but it's very difficult to consume. So our goal was to make this visual, let this be very impactful at a glance and on demand, and put those facts into the hands of the people who can action on them, rather than having to page through a book. So we have just deployed this to production. It's available to the public as of about 2 months ago. We worked on it for about a year. It was quite a pathway, but we've gotten there and it's available. But it's not complete. It's a starter home, as LaSharn and I would say. We like to say we just moved into our starter home, but we have plans. We have paint picked out. We have new floors picked out. And I know we're going to put in a swimming pool one day, and I'll go through and talk to you about some of the big ideas that we have. But first, I'd like to just kind of show you where we are, what our starter home looks like, because it's actually pretty good. It's pretty nice. And so you can see this on the screen. When you start, and bear with me while I navigate the machine here, but when you start to look at our product, you see state level data. And immediately you see that it's brightly colored, it draws your eye. And there are 4 key indicators, or 4 key metrics that we keep here on the very front. The first one is the total physicians' hours. The next one is the total count of physicians. The next one is the population of the area, which in this case is the state. And the one over here to the right is the number of physicians per 100,000 in population. So it's very simple. The numbers are there. We all know what those numbers are, but now we can see them here at a glance. Interestingly, these first 2 here are not available elsewhere. And this is a very important ratio. You want it to be about 1-to-1. You want the number of physicians and the number of hours that they work on a 40-hour equivalent work week to be the same. You don't want people working 1.5 persons hours. That would be an indicator of a problem. All right, and so down, if you would scroll down on our actual dashboard, the next thing you would see is data which is available in the book that LaSharn's team publishes. So this is physician distribution by age, and we have it by race, and we have it by gender. And it's information that's publicly and widely available, but if you notice, these charts and the visualizations make it so impactful and at a glance. If all you had was this, rows and columns, you might breeze over it. But if you notice something in a pie chart that looks way off, like, oops, that one's gone again too. Speaking of way off. I apologize, this presentation doesn't seem to be working well. But all that to say, we are providing these pie charts rather than the rows and columns so that you can consume the data and you can use it. So the real impact of this data comes down to the county level. Because state level data, it is an aggregate, it's an average. It's a story for our state, but it's not a story for a person. It's not my story or your story or someone's story who lives in a rural Georgia county. for example. So our platform allows for us to drill down easily from the state level into any of our counties across the state. You can type in the county name, it'll auto-complete, so it's super easy. You just click it, and then the county data comes up. And so you can draw an easy comparison. One of the comparisons that we have in the presentation, and hopefully we can send it out to you afterwards, is Cobb County. So Cobb County, suburban Atlanta, things are pretty good in Cobb County. If you look at their numbers, their ratio of physicians per 100,000 population is 185. Not too bad. So that is 2 per 1,000 in population. The hours to the number of physicians is almost 1 to 1. It's a little off, but not much. So it's actually quite good. And then we can compare it very easily through a drop-down menu to Clay County. Monty Veazey noted Clay County earlier. You all met the physician who works in Clay County via the video. So you can see on our dashboard a huge problem where the physician hours worked and the number of physicians is 2 to 1. This one physician is working double time to service this population of 3,100 people. And so if you were to extrapolate the 3,100 people in Clay County to physicians per 100,000, you'd have about 31 or 32. That's as compared to Cobb County's 185. And this tool doesn't change the data. It doesn't give any data that wasn't in rows and columns, but it puts that right at your fingertips. You can compare those two and you can see those problems. So we have deployed our starter home. We have the county data available, and we have some big plans. And part of that involves taking feedback and understanding what else can we do? What else can we put at your fingertips to help get these decisions made, get this data consumable into the hands of the people who can action on it? We're interested in taking feedback from the population now that it's out in the public. But we do have some ideas, and some of them are big ideas. Some of them are the swimming pool ideas, and some of them are the cans of paint, but they're all really important. So some of the ideas that we think for the future is to expand this data set. So it's not just the data that's being collected now on the license renewals, but we can expand the questions which are being asked. We can ask more about the details of the specialties that the physicians are working in. So we have a richer data set there. One question that I'd be really interested to ask, and Dr. Harmon alluded to, is how much of your time as a physician are you actually dealing with patients? He noted 6 hours a day in clicking onto a computer because of the electronic health records. That's important information because our hours versus physicians number could be way worse than we think. We just need richer data set. So as we go along, we're going to be talking about increasing the data set. What about community data? We might hear from these folks in Clay County, for example. How long did it take you to get this appointment with this doctor? How long did you wait in the waiting room? How far did you have to drive to get to your doctor? Do you have a car? Did you have to take public transportation or have a family member drive you? This is different data, but it's important data that with the technology that we have, we can layer on top to make our reports richer and more impactful and more consumable and able to be communicated to the people who can make a difference. So that's one place we might go. We have the cans of paint stuff that's a lot easier and quicker. We can re-visualize this data that we already have. So aside from gathering new data, which is kind of a long-term plan, we can work with the data that we have. It's begging to be put on a map. We can do that. We can map and highlight areas. We can say, just light up the areas where that ratio is off, the hours to the number of physicians. Or light up the areas where our service per 100,000 in population is way out of whack. And that way, at a glance, you can just kind of see that. And then you can click on it and drill in, get the details. You can run comparisons side by side of different counties. That's where we're going in the short term. In the longer term, a richer data set, also that we can help to service the populations of Georgia who need it. And beyond that, I'll be quick with this, but I do want to share that the office that I work for in the technology department is interested in hosting all of the state data, not just this data set, but other data sets, so that we can layer them together and really tell the story about our state and about our counties and about our communities. So we have this physician data. We have public health data, we have community data, we have school data, crime data, all can come together and really show what's happening in our communities. It's not siloed. They all influence each other. And that's what our office is working on as a long-term plan, to create a state data portal. And LaSharn's team is a foundational partner, and we're very grateful for that. And I would be glad to show you all a demo of the system if you want to catch after. I'm sorry that the presentation didn't work out the way that we had hoped, but there are some screenshots that I can show you, or I can actually get you into the live platform so you can play around with it and see some of the data. So thank you. Thank you for having me.
Excellent. All right, next up, please join me in welcoming Lucy Marion, who's the Dean of Augusta University College Nursing. Lucy, great to have you.
Thank you, Lieutenant Governor Cagle. Thank you for the invitation, and to all the other senators on this committee and everyone here. It's just such a pleasure and honor to be invited to speak about the nursing perspectives, particularly the APRN, the Advanced Practice Registered Nurse perspective on this healthcare reform and primary care. It's a topic near and dear to our hearts, and just great to be here. I am Lucy Marion. I am a family nurse practitioner, but no longer in practice for about 30 years. I started out in a upscale family practice. I was a faculty member the whole time that I was practicing, and then after about 10 years, I switched to people who live in shelters and live in public housing and who are in prison and that population. So I had a great time. All the way up till a few weeks ago with the evacuees in the shelters for the Hurricane Irma. So that's my love, and I want to share some of those stories as we go through. Now, I have a lot more slides than we have time for, because I wasn't sure exactly what each other speaker was going to say. So you'll see that there's duplication, so I'll skip through those, but we'll have them as a record for as we need to look at these as we go through. I will say that I'm the Dean of Augusta University College of Nursing, but in my past I've also been a researcher, and I do health behavior change. I'm sorry Dr. Harmon had to go, because I converted, was on a team of course, converting the diabetes prevention program, which was evidence-based and well researched in many populations, and we converted it for African American churches, and the nurses who were members of those churches were then rolled out the diabetes prevention program, and a very successful program there too. So that was near and dear. I've also worked with very high-risk populations to prevent sexually transmitted infections over the years. That was my first area of research. I will brag a little bit about our College of Nursing at Augusta University, but mostly I just want to let you know that's our name, because it's had 4 names in 5 years. And so you'll know that there really is an entity called that, and so we're celebrating our 75th anniversary. We've been consolidated with Augusta State. And I did want to say, just to start off with, all of our APRN specialties, the family nurse practitioner, peds, psych, mental health, adult, geri, acute, and nursing anesthesia are all now at the DNP, the doctoral level. So we don't have any master's programs left in those fields for us. And I'll stop with that about our great college of nursing. I'm going to talk a little bit about Georgia's overall health rankings, which you've already heard about, so we'll skip along through that, and you've already heard about the populations. And I'll talk a little bit about that, and just get right on down to the APRN. As quickly as I can. I know our time is short. So we get the numbers, and it's hard to keep up with these numbers, and if I read one ranking, it would be one thing, if I read it would be a little off. But basically, we're not where we want to be in the state of Georgia. We're in the lowest quartile overall, and there are a few areas of really a little bit of promise. Like our health behaviors are not as far down as I thought it would be with 32. But I was pleased about that, to tell you the truth. We do know we have 2 Georgias, our Healthcare Foundation, Is that? It's,
Healthcare
the foundation.
Healthcare Georgia
Yeah,
Foundation.
Foundation. I speak it all the time and then it sounds funny. But anyway, there were two Georgias, you know, we have Atlanta and then we have all the rest of us. And so you can see that with the light colors and the dark colors, and the lighter colors are in that metropolitan area. And the populations, we know that we're over 10 million people and we're growing fairly rapidly, more than 100,000 a year in the state, and Atlanta has, in the metropolitan area, has over half of us. And we have a high rate of poverty. You may see 15, you may see even some say 14, but it's a very high rate. We're ranking about 10th in the states in terms of people with poverty. And we have a lot of chronic disease. You hear that the AMA is very interested in this. Certainly everybody in Georgia is interested, everybody in the United States is interested in chronic disease, because this is a leading cause of premature deaths, and of course that's what we do in primary care. But look at all of the violence that take our people away. And of course a lot of those deaths, those premature deaths, are young people, which takes a lot more years away, and that's part of this calculation. So, and then of course we're right here in the heart and stroke belt, so we have a lot of disease to deal with. And we have low birth weight, and you've heard some of that. And we have drug deaths. See, we're not the worst. We're in crisis, but we're not the worst. So I did want to put up something that I don't want it to be too encouraging, because we have so much work to do, but when you look at the rest of the states. So I'm going to move on to our Georgia health systems, and you've been hearing people all day talk about the systems that we have and the delivery systems. And when I think about, and I didn't get them all here, these were just flight of ideas from the provider offices and all the different kinds of hospitals, be they psychiatric hospitals or their rehab hospitals, or their even the long-term care. But we have so many healthcare settings in our state, even in the sparsely populated. There's a health department and a school, a public school in every one. So that to me says hope, you know, it's light, it's people are there, it's brick and mortar, and do we max it out in Georgia? Are we taking advantage of all that we have here? We have that wonderful growing retail clinic network that can provide probably a lot more than they are providing, should they be engaged at a higher level. Just if nothing else, the med checks for our psych patients who don't have the ability to leave work for a whole day, or maybe something else in relation to chronic care. This is being done at other places. I know we are more limiting, deliberately limiting of those activities in those clinics right now. But then, of course, we have all the home health, and almost every home can be reached. They may not have any connectivity there, but they can be reached. So all of the delivery systems that we have, we're still not ranked high. You can see, as a matter of fact, we're ranked really low in these health system performances, and that's probably more hospital, but it does include more than. But the connectivity, you heard Dr. Hensel's video, that she actually has some connectivity, but it's too slow to get anything done. And I found that to be true with a lot of the work that I was trying to do out in just taking education throughout the state. When we first rolled out our doctor of nursing practice, even the university system did not have adequate connectivity. Now that's changing a lot. And of course the EHRs, as onerous as they are, as you heard Dr. Harmon talk about the hours, they are absolutely essential for us to do our work. The job is to get those IT folks to move us ahead in the utility of all of these. And then, of course, the health information exchanges. I was hearing about here in this area how they have active health information exchange. And for those of you who may not know what that means, is it means that the faith-based clinics in Augusta can get their ED reports without having to get a hand-copied form like we used to have. Or, for example, when we were managing the evacuees from Savannah, and they were coming from Matthew and Irma, we already had their records before they got there. They were on a bus, and some of them were on ambulances, and they were on all kinds of of transportation, but we knew who was coming, and we were able to get their meds ready, and their rooms ready, and the ICUs ready. And it gives me cold chills just thinking about what really was done that time because of the HIEs that were going on. And then, of course, we have these ideas of having hub and spoke. And that's the only way, in my mind, that we'll ever get Georgia really covered. And so we have these hubs and we have these spokes. And we figure out what is the most effective and efficient way to use that hub and spoke, and who is that provider who would be best to be the hub, the spoke, and most cost-effective, and still get the highest quality. And we'll do that because we have that in mind, but it's a long road to hoe. And of course, our system, we've already heard, we don't have enough coverage for our people for health care, and the providers who are serving insured people are the ones that are losing the resources to do all that they can do. And of course, we didn't have Medicaid expansion, and the states that didn't have Medicaid expansion, of course, have continued to have the problems. And you can see, according to this slide, that the 2.6 million non-elderly adults fall into the coverage gap, and most of them reside here in the South. So talk a little bit about our workforce here in Georgia, and I put this map here, and it reflects that if we had plenty of coverage, Georgia would be pretty clear colored there. And this just shows you that there are very few counties that really have enough coverage except for that metropolitan area again. Now, we do not put APRNs and PAs into this data set. So I'm really looking forward to what our new workforce board that will be looking at nursing data will be able to do, and to include these APRNs. The only reason we have APRN data is because we went to a foundation to get money to analyze the data, and actually we went to the state legislature who supported us in funding, recoding our relicensure format so that we could find out where people are actually practicing and so on, so we appreciate that. We did have a landmark study in 2010, it was published in 2010, that was conducted by the IOM. It was reminiscent of the Flexner report back in the early 1900s when it turned medicine around. And this has been driving us, and I won't spend time going through this study. It was done again by the IOM, it was done by a team of researchers, and everything that they recommended was based on evidence. And I'm going to be focusing here pretty much on scope of practice and practice barriers, so that APRNs can make this maximum contribution to healthcare in the state of Georgia. There are other important things in here that you can look at and read that report, because it is filled with research to support all of these issues. Our workforce in nursing overall in Georgia is growing. It's growing rapidly for a lot of different reasons. Our colleges of nursing, the schools of nursing, and departments of nursing really put their minds to it in about 2006. I think is when we started that task force, and we said, look, we need to at least double our output with new nurses into the system, and we've gone beyond that, and we continue to grow. At one time, we had about 30 programs to start to prepare new nurses, and now we have 50 programs to start to educate new nurses. And we have about 30,000 licensed practical nurses. We have 131 RNs and 131,000 RNs, and that's not counting any of the APRNs. And we have between 12 and 13,000 APRNs in the state. Now, I can tell you that's not how many, though, are practicing. We think we have between 80 and 90, probably getting closer to 90,000 RNs practicing in the state, and closer to 10,000 APRNs total practicing in the state. A lot of people have double licenses, and we're just now beginning to figure out where people are actually practicing in the state. In primary care, I deliberately wanted you to see that the APRNs and the physicians have essentially the same categories of practice. Nursing has a different emphasis on its care, and physicians have a different emphasis, but we all need to get to the same place, and that is to manage chronic illnesses and help people to take care of themselves better and to prevent as much as possible. I'm going to focus mostly on nurse practitioners today, but our nurse midwives, the 500 something that we have in the state, are very functioning. Most of them, if not all of them, many of them, if not most of them, have dual preparation. They're family nurse practitioners, they're women's health nurse practitioners as well. So I just wanted to show you that the education of these primary care providers varies. Physicians are very clear. They have the 11 years. Dr. Harmer was talking about 12 years. But to become a family physician, it usually takes about 11 years. And to become a master's prepared nurse practitioner, it takes probably on average of closer to 7 years. There are some shortcuts for certain types. But now with the new doctorate of nursing practice, it definitely is taking 8 years. There are some shortcuts there because people go through a program in 3 years and so on. But just to let those people who worry about education of APRNs, it really is high quality, rigorous, demanding education with a lot of clinical hours. And when we started the DNP, we were able to double the clinical hours. And many people get more than that. So we do have well-educated APRNs. And for the people in the audience who don't understand all of this, I just will say that to move to the advanced level, you get a baccalaureate degree in nursing. There are some who get a master's degree in nursing first, but you do get that basic preparation at the collegiate level. And then you move on to, and you'll see here we have the roles and the population. All of our advanced practice nurses are population focused. And so we are population specialists, and you can see that here as well. And then after becoming an APRN, there are now opportunities to go into fellowships. And they're usually lined up with medical fellowships, and often they're taught together and take them to the next level. So, like for example, I think I have a slide in this. Maybe not. For example, Emory has a fellowship for APRNs in emergency care or transitional care. We are working on an emergency care fellowship at our place. But at Carolinas, I think they have 22 already. They've had hundreds and hundreds and hundreds, if not 1,000 now, to go through that. Duke has it, Mayo has it, and so this is definitely growing, and these will be major providers for them. So why would we have an APRN? Well, we have lots of evidence indicating that they're cost saving, they're high quality, that they meet a great need that we're not meeting now. And I have this infomercial kind of infographic about nurse practitioners, and this is filled with data that I won't go in part by part about why nurse practitioners, the cost, the quality, the education, and so on, and how many we have of those. In our state, we're doing very well. You can see that we have more nurse practitioners per capita than many of the other states, most other states. We don't have as many, but we have very high number there. And this is our distribution in Georgia. Of course, you can't see that. But we now have the newer data. This was about 3 or 4 years ago. Now we have data that we're ready to analyze. And so this number is increasing. And nurse practitioners are willing to go into primary care, rural areas, underserved areas. It's part of their training. It's what they like to do. And we're definitely ready for that. And this was to think about the economic impact of an APRN in a community. We're actually looking at some research right now to study this, not just economic. So these are some economic indicators of what happens when you put an APRN or a PA in the community. But they do much more. They're community members. They go to the church. They donate. They have sick call in the morning before they go to work. Their nurses are good members of the community. So when we're able to put APRNs in there, they can take that value much beyond than what we have here. You're probably wondering what this DNP is, for those of you who are not in the field right now. But it is a practice doctorate. The medical degree is a practice doctorate, the dental degree. But think about the PharmD. I think it's the easiest one to transition in a lot of people's mind. At one time, the PharmD decided we need a practice doctorate. And so they taught out everybody, they had all the people with the baccalaureate degree. And now now they're required this. And so we're not doing that yet in nursing, we're not required it, but the nurse anesthetists have. So they're moving very quickly to the DNP, and increasingly we will move toward that too. So that we'll have to make sure we teach out and we take care of all of those great master's prepared APRNs, because they have done a fabulous job. But we are in transition, and it will take several years to do that. But this is going to be the new team. This is the one where there'll be different leaders for different aspects of the health care. So let's talk a little bit about a state practice environment. Now, I'm sorry to tell you that the state of Georgia is the most restrictive of all states in the United States for APRN practice. We have a physician collaboration that's mandated and with oversight of reviewing records. We have ratios to deal with. We have Schedule II restriction that we're prohibited from of the drugs when it's necessary in our jobs. We have restrictions on our ordering radiology exams, radiological exams. So just that radiological exam is very hampering to our practice, and that is what makes us the most restrictive in the United States. We have 22 states that have no restrictions at all. We have the veterans system that has no restrictions at all. As a matter of fact, I was talking to one of my mentees who's moved to the Columbia VA, William J. Ryan Dorn VA, where he is the medical officer for the women's health unit there. So it's not what we aspire to do, it's just what happens when you have the expertise, the competency, and so on. So these barriers, what are these barriers? What do they do to our practice? Why do we care? Is it just a matter of pride? Is it just something that we're just particular about, or no? It decreases access to care. The states that have full practice have better access to care. Their costs are lower. So it's a costly waste of time, physician and APRN. When I was first a nurse practitioner, I had to see my client, go stand in the hallway, wait till the physician came out. I'd already filled out the prescription, and he or she would have to sign it. That took time. I could have been seeing somebody else by that time, and this goes on and on. It delays it for the patient. The care is discontinuous. They can't get the pain management. They can't get their test in a timely manner. And it's disruptive communications. I hear our APRNs say they order a test, they put a physician's name on it. The test goes back to the physician gets the test, it gets lost, it gets back. The call is not made as quickly, and it goes on and on. And we have no opportunity to employ MDs. If we wanted to start up a little clinic down in my little hometown of Scotland, Georgia, with 300 people, if I wanted to do that, it would be, I would have to use duct tape. I like that term. You know, duct tape, you have to fix it. You have to work around it. You still make it work, but you pay the price for it. And then, of course, we have many APRN services that are prohibited. It wasn't even the intention of it, but because we keep putting provider-specific language into various institutional regulations or sometimes the law, but we watch the law pretty well now, thanks to our help. It's a good helper. So, all right, so what are our recommendations? We too believe in hub and spoke. We do believe to reach out, we're going to have bodies of people, teams with expertise, with a lot of telehealth, telemed, and all that. We do believe that APRNs can serve in many of these roles. And just an example is the EICU. Now, I don't believe we have EICUs in Georgia yet, but we may. But I came from a place years ago that already had EICUs, but they had the intensivist in a control room watching every ICU patient in 10 hospitals. So the nurse in the ICU could get instant help, the ICU, the intensivist team could give immediate advice. And so this is hub and spoke. What could we do with, and the VA's using hub and spoke. They have an APRN in the large center, and they have an RN with the veteran in Statesboro, Georgia. And so those two are communicating, and then the veteran does not have to come to Augusta for the care. So, and then of course using telehealth, the HIE, networks of all kinds, and then to remove these practice barriers. We need to be systematic about this, and there's no evidence to support any of these. We have study after study, after hundreds of studies, they're even studying it internationally now, the last one that I read. So we need to do that in Georgia too. We don't have to worry that nurse practitioners and nurse midwives are not well educated. They are well educated. And a review of a few records does not change the quality of practice. There's no evidence to show that as well. So there you go. The third one that I would say is we need those incentives. We've already heard about those. Sharon Hughes was talking about it. We need some incentives for startups. Nurses, there are many nurse-managed centers in this United States. There are nurse-managed centers right here in Georgia. All of the retail clinics are. There may be PA managed as well. But think about the school-based clinics and so on. I've run many nurse-managed centers. I ran clinics where we integrated mental and physical health care for people with serious mental illness. Now, where can you get that in the state of Georgia, where you really have the same team taking care of all with serious mental illness, people off the streets? I'm sure we have some of it particularly in our faith-based clinics, where they make every effort to bring that together and so on. But so I would say, let's see what else I have to say. And then my final slide is our work with Irma. And we had 41 students out. We were working night shift, day shift, 12-hour shifts. We had 20 faculty members. This left-hand corner was when we were getting everybody ready to get on the buses. The students were there at 4 o'clock in the morning and giving the insulin, checking the blood sugars, getting insulin, packing up everybody, and putting them on the bus back to Savannah. One of the great times that we had. And here, the greatest shortage was prescribers. We struggled with not having a prescriber. We didn't even call them providers. Because we knew we just needed that prescription so we could, because they forgot their meds. Or they ran out of their meds. And so we had residents, we had APRNs, we had physicians. We were glad to have them all. There was no hierarchy there. And it really made a difference. And we sent them back home. So thank you very much, and appreciate your listening to this story that I have.
Wonderful. Thank you very much. Next up, I'd like to, our final presenter for today, Jeff Selberg, who is coming around. He's a senior advisor to the Peterson Center on Healthcare, and it is a real honor to have him today. He has traveled to Georgia to be with us today, and we appreciate your time. Thank you.
Lieutenant Governor, Senators, members of the task force, thank you very much for inviting me to this beautiful place. I can't really say that I've been in Georgia when I say I've only flown through Atlanta. And so this is my first trip to Rome. And I live in a beautiful place. I live right outside of Boston. But this is a beautiful place, I must say. So it has beautiful people, and we want to make sure that we do what we can. As I said, they're not only beautiful, but they're healthy, and they get the right kind of health care. Tell you a little bit about my background, and then I'll accelerate the presentation because I know we're running a little bit late. My background, I grew up in the Pacific Northwest and then became a nomad in healthcare. I started working in hospitals as an orderly in 1967. I left hospitals as a chief executive in 2010. My last appointment was as CEO of a 3-hospital system in Denver. I went on then to the Institute for Healthcare Improvement, organization that was started by Don Berwick. And Don and a few of his friends created something that's probably well known to you, the triple aim: better health care at a lower per capita cost. I was there as the chief operating officer for a little over 3 years. And then Pete and Michael Peterson came calling and asked me to help them shape and oversee the Peterson Center on healthcare. One of the things that I wanted to describe, and I'm going to blow through this exercise just because of the time, but I'll still ask you the question. When Pete and Michael asked me to help them shape and oversee the Peterson Center, the thing we decided to do is ask ourselves, well, what problem are we trying to solve? And you've heard healthcare characterized as complicated. You've heard healthcare as the blang man and the elephant. I would suggest to you that it's a herd of elephants. You can go to coverage, you can go to delivery, you can go to value-based payment. Each one of those has its own complexity. But you might ask yourself, what is the problem you're trying to solve? And what are your 3 top strategies in solving it? Now, I hope to express what we decided to do through the course of this presentation. So I'm going to go through the Peterson Center on Healthcare, and I'll tell you a little bit about Pete along the way. I'll talk about our approach to data and analytics. I think the main event in this presentation is what we're doing in primary care, and I will speak to this concept of direct primary care that has come up. What our research has shown us in high-need patients, and then give you some other sources of information. And my understanding is this should get done by 2 o'clock. Is that correct? Right on.
That should be great.
Okay, we'll see if we can do that. Peterson Center on Healthcare. Pete Peterson. Pete was President Nixon's lead economic advisor. He went on to be Secretary of Commerce. He went into a storied career on Wall Street, ran Lehman Brothers for 10 years, then created Blackstone. Blackstone went public in 2007. That's when the 11 or how many digits showed up in his bank account. He started the Peterson Foundation. The Peterson Center is a division of the foundation. The express purpose of the foundation is to really understand what the federal government is spending and why, and how to balance what comes in as federal revenues and what goes out as federal expense, with a deep concern about deficit and deficit spending. As we know, 70% of the federal growth spending will be in health care. So it stood to reason, Pete and Michael believe, Michael being Pete's son, that they needed to get into health care to meet their mission as the Peterson Foundation. Secondly, if you look at variation analysis across the country, and depending on the audience I'm speaking with, I will say that 68% of the GDP is outright wasted, or it's questionable, or we ought to really look at the $3.2 trillion, because chances are about $800 billion to $1 trillion really doesn't have documented value. That is a lot of resource that could go to something that would be more valuable. The question is how do you get to a point where you can lower your per capita cost to that degree and have better rather than worse outcomes? And I'll describe how we chose to approach that. Our feeling is that the unique challenge is practice and delivery. There is policy. It's a question of how you synchronize policy and practice. In other words, when I was in the field, when I got a new policy, a new payment scheme, I had very smart people who could figure out how to work around that new payment approach. Don't do any changing in how we deliver care. Just figure out how to deal with the reimbursement. That's not the intention, right? The intention is to improve care. So the policymakers, from our perspective, need to be as concerned with what are the new practice models that need to be spread and scaled throughout the healthcare system, along with the policy. So our mission is to transform U.S. healthcare into a high-performance system by finding innovative solutions that improve quality, lower costs, and accelerate their adoption. And you can see the key words there in terms of accelerated adoption, innovative solutions, and national scale. Yes, we want to bend the cost curve, and we want to bend the cost curve significantly. We believe we can do it and improve outcomes at the same time, and we'll talk about that in primary Care. We believe quality, and I got this from IHI, quality and cost can be mutually inclusive, not exclusive. So what are our program areas? Accelerating adoption, performance and measurement, and fostering conditions for change. 75% of what we do is accelerating adoption. And our assumption is that there is white space around accelerating adoptions. When I was at the Institute for Healthcare Improvement, I would have practitioners come up to me and say, Jeff, I know the what. What I need to know is the how. How do I take this so-called model of care and bring it in to my institution, whether it's a primary care practice, a hospital, post-acute, or whatever. So we decided that that's where we were going to focus. That's the problem that we felt we needed to solve. So I won't go through this slide. These are the grants. We are both a grant-making foundation as well as an operating foundation. In other words, we actually have an operating arm that is attempting to spread the models that we've identified and validated. Chart here in terms of the approach that we're taking as far as spread. You'll see private equity terms here. That's who our benefactors are, Pete and Michael Peterson, limited market test, initial market distribution, mass market distribution, and the key elements. The first column has to do with doing research to identify and validate the models. And then we ask ourselves, how do we create a change package that can help someone who's committed to bringing this model into their practice or into their hospital? And how do we do that on a very limited basis so we can really learn what it takes? And then how do we scale it up? And how do we reduce the cost of the spread as we get to a larger and larger market effort? Data and analytics. You've heard a lot about how important data is, and we certainly agree. We want to know about trends in the health of the population. You've heard about life expectancy today, premature death. We would say that disability-adjusted life years are as important. This is a measure established by Chris Murray and the World Health Organization. And what it does is it assigns years of disability along with years of premature death. Why that's important is that if you look at premature death only, ischemic heart disease is number one, for sure. If you look at years of disability only, behavioral health and addiction is head and shoulders above everything else. So again, what problem do you want to solve? You want to solve every problem, but you're going to have to prioritize. We know that we're in a very inefficient market in healthcare, again, a private equity term, meaning that there's a tremendous amount of variation in cost and quality across communities, across states, across the nation. And so we can look at that as a negative in the sense that there's a lot of high utilizers out there that don't do very well by virtue of the outcomes they produce, but there's also bright spots. And it's the bright spots that we're looking for. The other thing that we want to do is we want to understand the total spend, not the total spend from the perspective of premium, but the total spend in terms of resources consumed and the cost of those resources consumed. And we want to look at how does population drive that? How does age drive that? How does the burden of disease drive that? Interestingly, over the last 15 years in the work that we've just funded and we're getting some feedback, incidence really has not changed, believe it or not. You would think with the obesity, epidemic, diabetes, incidence has gone way up. Actually, there have been offsets. Price and intensity of services is what's driven 50% of the increase in the spend, which is $1 trillion over the last 16 years. And so we want to look at price and intensity. Unfortunately, there are situations where as organizations lose volume, they price up to offset that decrease in volume. How do you deal with that from a policy and spend perspective? So we've put this diagram together, this approach together in terms of data. We want to develop actionable insights from a national, regional, local, and provider attributed settings. What's the difference between local and provider? Well, we know providers have attributed patients that aren't all from the same local setting. But we also want to know by zip code and by county how we're doing. We want to identify bright spots. We also want to identify, using as good research as we can, What is the result of our improvement efforts and other improvement efforts in terms of the health of the community and the spend, as well as the experience of care of the patients? And we do believe in markets. Now, this is a provocative statement in the sense that we want to create an improved, discerning market that drives innovation. Right now, innovation pretty much layers additional costs onto the spend because our providing community is not really driven to improve outcomes at reduced costs. Not the way that a market would work. And the issue there, of course, is opaqueness and a lack of transparency in the market that we would like to change. So we're looking for data at all levels. We're looking at various methods that you see here in terms of global payer disease, payer analysis, and the like. We want to develop an investment strategy, not only for the Peterson Center, but perhaps for all of healthcare. We also want to understand what delivery system initiatives we should focus on and what we ought to lobby for others to focus on. And yes, there are policy initiatives. And yes, we do want to develop research and have those results published. We have something called the Peterson Kaiser Family Foundation Tracker that expresses all of this on the website that you can look up. We want to have convenings about, well, what does this really mean to you as well as for us? And we want to make very specific investments as a result of what we find in the data. Unfortunately, this kind of data is very hard to access. I think there are 19 all-payer claims databases across the country at various levels, forms of capability. We're developing our own approach with the Kaiser Family Foundation, the Institute for Health Metrics and Evaluation out of Seattle, and the Dartmouth Health Atlas people to see what we can do in this regard. Here are questions that we're asking ourselves. Pete Peterson at 91 is saying, in my lifetime, Jeff, tell me whether or not healthcare on a national level is improving value, is flat, or is degrading. And it's harder than you think in terms of really understanding, well, what should the numerator be? Health of the community, experience of care, and how do we measure the spend? So, but we're working on it, and all these other elements. From a legislative standpoint, from a regulatory standpoint, there really needs to be something done about access to data and the liquidity of data. It's just way too hard to get it, and it's way too expensive to get it. And until it's more transparent, we're going to have these kinds of issues. Primary care, all right. This was our first effort in identifying what we call an exemplary model of care. And the way we did it is we went to Stanford University, the Clinical Excellence Research Center, or what we call CERC. The director is a physician by the name of Arnie Milstein, who's done a lot of work in this arena. Arnie went to a very, very large commercial claims database of well over 50 million lives, and he asked two questions. Who is in the top quartile using HEDIS measures, health effectiveness data information system measures? And who is in the lower quartile in terms of total cost of care? Not just the total cost of care that goes on in the primary care practice, but for the attributed patients, total, all-in cost of care. And what practices do both? Top quartile HEDIS, lower quartile total cost of care. About 5% of the practices, 15,000 practices that Arnie surveyed, did both. They did both. You can be high quality and low cost. Some of these practices on a total cost of care, risk adjusted, were somewhere between 25 and 50% lower per capita than the average. So how did they do this? What Arnie did is he went out and he surveyed, site visited 11 practices across the country. Now these aren't Mayo Clinic or Kaiser Permanente. These are Main Street type practices. He visited them and he tried to identify the features, and he did. These are the 10 features that are listed on this slide. And then he went to practices of what we'll call average performance in terms of total cost and HEDIS measures. And he tried to identify if those features that are identified here actually also existed in practices of average performance, and he found that for the most part, they did not. So his feeling is that if a practice has these features, they can lead to exemplary performance, and that's what we're testing right now. So what are those features? Well, there's 3 categories. Building a very deep relationship with the patients you care for. 2, saying as a practitioner, as someone responsible for patients, I will take responsibility for all the care that is provided to you, whether I provide it myself, whether it's provided in my clinic, or it's provided out there in a specialist's office or in a hospital. I will take responsibility for coordinating. And then thirdly, how do you do that? Well, these practices really focused on building team and what's called upshifting the capability, working at the top of your licensure, which we just heard about, and working as a team and having very, very good data to be able to risk adjust and identify who are the patients that you have in your panel that need the most care, whether it's in a medical model or it's adjacent social services. So those are the key elements that you see under each one of those categories. And I would say that the critical pieces are working as a team, always being accessible, really understanding your patients, and having an attitude that it's a partnership. We didn't hear anything about compliance here in these practices. I can remember Arnie talking about speaking with physicians who said, it's really about us working together. It's not about, hey, you didn't do what I said, so it's your problem. So a real sense of partnership and team. Now this is quite a transformation, and I suspect that there's a number of you out in the room, because there is every time, how could you possibly have time to do this? What's the financing model that would allow this to really happen beyond just those spectacular physician leaders who just do it because they feel it's the right thing to do? So we addressed that. And what we said was, we're going to have to build a change package here that breaks down these features into clinical processes and administrative processes. And that's what we did. And it came up to well over 100 future state functions. This is like a wiring diagram for a jet engine. And I can remember people saying to me in change management, the change management gurus, if you want to spread something, simplify it. This is not simple. So we realized that we've got to sift this down to the high leverage elements. So what's the process? Well, it's a real process of engagement where you have the leadership and you engage the leadership and you say, what are your pain points? What are the things that concern you most? And you've heard it today in terms of, I'm at the computer too much, I'm doing too much administrative stuff, I don't know my patients, I'm burning out, this is not what I went to medical school for, or nursing school for, or pharmacy school for, or medical assistant school for. Right. And it was very interesting in terms of the 11 practices that were surveyed, very high level of engagement on the patients, and very, very high level of engagement, joy in work, on the part of the clinical team. So this is about work. This is about workflow. This is about design. So we worked with small groups of leaders to say, why do you want to do this? What is it that you need to do? How can we help you with the how in terms of what we call a plan, do, study, act cycle approach? And then how can we spread the results, real results, both in terms of published articles that stand the scrutiny of researchers and testimonials. So I was going to go through exactly where we are in this diagram in terms of how we spread, and you can see it's very early days. We've done our limited market test with just 3 practices, one in New York City, one in Minnesota, one in Missouri. We feel very good about replicating the features. These were practices that had average results, but had leadership that was passionate about doing it better. high-need patients. Heard a bunch about high-need patients earlier through the course of the day. This is a diagram that is the 50% is 5%, and actually about 22% is 1%. So there's a very high concentration of spend on a very low concentration of patients. Unfortunately, they're very diverse. They are not just the frail elderly. And we took a look at these patients from the standpoint of total accrued costs, the intensity of care utilized over multiple years. And we found that not all high-need patients in 2016 were the high-need patients in 17, and probably won't in 18. So it's a population that changes. We also found that functional limitations plays very large role here, beyond the medical model. And so you have to go to the social and behavioral services if you're going to adequately care for this group. This is the beginning of what they call a taxonomy. In other words, who are these high-need patients? And you can see it, everyone from children with complex needs to non-elderly, disabled, working across to advancing illness. Advancing illness, still serious illness management, those last months in life. And we know there's a medical model piece that requires coordination, but there's also a behavioral piece, and there are social factors that need to be integrated. How do you do that? These are programs that we identified through the National Academy of Medicine, formerly the IOM, that said, hey, these systems here, these approaches to care really do a terrific job for this specific patient population. But that's not actionable. So we said, what are the barriers? And you can see the financial incentives and services. You know all this. There's fragmentation, there are workforce training issues, and the data systems are really, really poor. And we identify what we thought the policy solutions needed to be, and we handed that over to organizations like the Bipartisan Policy Center or the Commonwealth Fund or the Robert Wood Johnson Foundation that's much more adept than we are in policy. So we asked ourselves, well, we've got all this information and we've got this wonderful workbook. We have a playbook that we worked, IHI put together for us. We have a workbook as far as the National Academy of Medicine putting it together. And typically what happens with foundations like us is to say we're done. Now someone translate this and go to work. That doesn't happen to the scale we believe that it's necessary. So we said, what's our remaining work? Well, the taxonomy needs a lot of work. We need to be thinking about what do we mean by integrating and coordinating delivery of medical, social, and behavioral services? How do we scale this program? There's a concept in spreading and scaling called what is the scalable unit? The scalable unit in primary care is the practice site as we see it. Now that could be a community health center, that could be a one physician practice site, that can be a satellite of a hospital, but there's something that goes on that's defined in that site in terms of care. When it comes to high-need patients, it really depends on what population segment in that taxonomy we're talking about. We need payment reform efforts for sure. We need measures in terms of outcomes because the measures for outcomes, the HEDIS measures, don't work for this population. And we need to create those change packages, and we need to start working. Now, we're not the only ones doing this. This is an organization, the National Center for Complex Health and Social Needs. Some of you may have read Atul Gawande's article a while ago in the New Yorker in terms of called Hotspotting. This is the Camden Coalition, is the organization that started that. There's a primary care physician by the name of Jeff Brenner, who was working with the hospital system in Camden, and he started asking himself a question: where are these patients that come into the emergency department here? Where do they live? is there something common about where they live? Is there something upstream that we ought to be looking at? And he found, as he did his research, that yes, there were some common elements in terms of where they live. In terms of asthma, for example, where you live has a lot to do with the care onset. That built out into something that was developed under Jeff's leadership, where he started saying, I've got to get a lot of people together to talk about this. They did the hot spotters, and then they started developing an incubator. And they became the kind of the trusted partner convener and catalyst for change in Canada. Now, lest you think, hey, they've got the Rosetta Stone on this, they do to some degree in that they can show that they have reduced ED utilization, hospitalizations, reduction in length of stay, the patient experience is much better, and the healthcare outcomes are better. But this is what they believe they need to coordinate in terms of services. So it's a big, big, big job. Jeff has moved on to United Healthcare, interestingly enough, because United has assured him they want to facilitate this kind of integrated delivery that involves really 4 quadrants. It involves the medical model, it involves behavioral, it involves social, and it involves addiction. They feel strongly that behavioral and addiction should be separated. They're 2 different issues. We're following them very, very closely because we feel, and there are others, that as we move forward, we can distill what the critical elements are to serve these people better. I have no doubt in my mind that we can improve outcomes and reduce the cost dramatically if we're strong enough and have the will to find these outstanding programs, understand how to design both the clinical and administrative workflows, do the hard work of evangelizing, and that's what it takes, with good data, and help people find their way to transforming their practices, their hospitals, whatever it is they do, and find their way to being outstanding in healthcare. The last point. When I was at the Institute for Healthcare Improvement, we would have this steady stream of people from Denmark, Sweden, Singapore, Norway. I mean, countries that just knock it out of the park in terms of quality and cost. And I would always ask them, why are you coming here? We're kind of at the bottom of the rung in terms of health systems with other high-income countries. The answer was always the same. It was, you guys have these bright spots. You have these outstanding programs that we want to learn from and export. And that's when I realized it isn't about inventing things. It's about creating the conditions to spread what's already been invented. So perhaps if you choose, if that's the problem you want to solve, we're here to help. Actually, we're here to help no matter what healthcare problem you want to solve. And here's some names of some people that were very helpful to me and could be helpful to you in terms of, I think, being very, very like-minded in finding ways to improve the health and healthcare for 10 million folks who reside in Georgia and do it in a way that brings the cost curve down as opposed to having it go up and just consuming everything inside. Thank you very much.
Senator?
Yeah, I just, sorry. Just on the data piece?
Yes.
You were saying it's really hard to get all this data, and I was just wondering at the state level if you have any suggestions on where to start to pull our data together.
Well, I would say that in working with the health plans where we've had the most difficulty because they consider the data proprietary, is I think to their defense, what they say is, can you tell us what you're going to do with it? And it's kind of like, well, we want to do a lot of things with it, just give us the data. We have been working with Dartmouth and the Institute for Health Metrics and Evaluation, and when we say we want the data for improvement efforts, we want to bring the data back to the practitioners that we're working with, who want the data to see if in fact they're improving, things open up. So my suggestion is, if you can be as specific as you can in terms of what you want to use the data for, and how the data, what data you need, not only what data you need, but how you want it put in what kind of presentation, it's going to be helpful. Does Georgia have an all-payer claims database? No. It's something to consider. To think through. Sounds like politically might be a tough threshold to overcome. The best claims database I've seen is in Colorado. If you want to check. I didn't really answer the question about direct primary care. Do I have a minute to do that?
You do.
Yeah.
We pay good money to have you here. So
Okay.
Let's see.
So I mentioned what I felt the characteristics were of exemplary primary care. My view is that if you're going to organize something around this concept of direct primary care, you need to start with defining what exemplary primary care is first. Now the question is how to finance it. And there were some comments earlier today about, boy, it's hard for a primary care, small primary care practice to take full capitation. Boy, I totally agree with that. So how could you develop something where there are incentives for the primary care team, using team, led by physicians, who have an incentive as they bring down the cost, the total cost of care, and they improve the outcomes of the patients that they're responsible for, that there is a gain. There is a financial gain. Even with that, there's the question then, well, how do I have the capital to transform my practice in the first place? Who provides me that capital? Now that's something we're looking at as a foundation, and we hope to bring other foundations into this, and other professional organizations. You know, it's possible that you could create a financing approach that says, you know what, let's make it out of pocket. Let's make it $50 a month. You pay a primary care practice $50 a month, $600 a year, and you're going to have access to these services. It's out of pocket. Boy, if you could make it part of the deductible, that'd be great. Now the health plans may have something to say about that. But if you could do that, my interest in that is, that's half of it. Half of it is the financing. The other half is, are these primary care practices supported to the degree that they need to be to practice along the lines of what I've described here? They don't have to do it exactly the way I'm saying, but the characteristics need to be there. And if you can build something like that, I think it would change the course of health and healthcare in this state.
Wonderful, Jeff. Thank you so very much. Very, very good. Very good. Wow, well, that concludes today. I will tell you that we probably will not, this is obviously our last task force meeting, so we did pack an awful lot in, but the presenters were absolutely wonderful, and I know that in the room there are those that have certain specific views on issues, and some of the presenters you may agree with and others you may disagree, but obviously diversity of thought is something that I personally take a great value, place a great value in, and I know that the committee members do as well. Each of the presenters did a very, very good job, and this has been a wonderful time together, and I want to say thank you to each of the members for your dedication, your diligence, not only in being in attendance, but also being willing to digest all the information by which we have received, not just today, but over the course of the task force itself. Many of you, I think, in the audience have also asked, when do we think we'll have a report and what will the report reflect? I anticipate that we will have a report, and it will be certainly at least by January or early January would be my expectation, and it should be very thoughtful in terms of what the options moving forward would consist of, both in terms of action items that could occur in this legislative session, but also obviously much larger conversations to point to a direction for the very near future. And I think all of you know what our goals and objectives are in terms of our priority for healthcare in our state. And we look forward to those recommendations and continuing to work very closely with you. Again, thank you to all the presenters. Thank you, senators, and also thank you to Berry College for a wonderful facility and a wonderful host here today. And we appreciate each of you being here. Thank you. God bless. Safe travels.